Good evening. So welcome to the 12th Annual Cole Eye Institute Imaging Summit. First talk's by Aaron Lee, talking about building the next generation medical imaging data sets for AI. Aaron.
Okay, so around the over the years, I've given a lot of talks about AI, and almost always people come up to me and they want to use AI for their data sets. As they're telling me about their data, I'm usually sort of kind of building this sort of graph in my head, where on the x-axis you have the number of different subjects, and on the y-axis you have the different measurements that you've performed. And almost always people are talking about their data that lives sort of in the upper left of this graph. And that's not really good data for machine learning because of this thing called the curse of dimensionality. What you really want to do deep learning or machine learning with is a high number of independent observations with relatively few key measurements done on them. And one of the ballpark numbers is that you need about 1,000 independent observations per class or per state of a disease for deep learning. One of the most successful data sets that has been used for doing AI work is the UK Biobank. And this is an effort that has been ongoing for decades now. It's really had a tremendous amount of success. There's about 15 petabytes of data, 2,000 ongoing global research projects, and about 200 or so papers have been published in the Nature family journals. One paper that came out of this sort of rocked our world. This is a work done by the Google group that showed that using deep learning and AI with the UK Biobank, they were able to show that you could, an AI model could predict whether somebody, how old somebody was, what their smoking status was, what their hemoglobin A1C was, and the thing that really shocked everybody was the biologic sex. We had been staring at the retinas for centuries, and we didn't realize that you could figure out somebody's sex based on a color fundus photo. They've gone on to do other work that showed that you could predict somebody's anemia status as well. So it's really powerful what they've been able to do using the UK Biobank. There's this issue of bias, though, with the UK Biobank. And one of the issues is that in order to have as many people as they did, they had to do convenient sampling. Basically, anybody who was willing to walk through the door, they took their pictures and their blood. And so what that led to is a situation where even common diseases are really uncommon in the UK Biobank. On top of that, it's very heavily white British. In fact, it's about 95% white British. This leads to sort of a strange situation where there's a healthy volunteer bias, such that if you want to live 10 years longer than anybody else in the UK, you sign up for the UK Biobank. The NIH really sort of looked at some of these efforts, and they realized that something was missing in the US, that they didn't have these big global efforts to build flagship data sets for AI. And so they put out this grant called, for a new program called Bridge to AI. And this isn't at the NEI, this is at the NIH Common Fund level. And through a very competitive process, the Cecilia and I's project got chosen to be one of the 4 data generation projects as part of this program. And our project is called AI Ready. It stands for AI Ready and Equitable Atlas for Diabetes Insights. And what we're trying to do is build a data set that could be used to study type 2 diabetes. And so the overall goal is to create a multidimensional, ethically sourced data set in diverse people for studying salutogenesis in type 2 diabetes. You probably understood most of the words in that sentence except for the word salutogenesis. And so what is salutogenesis? It's actually the opposite of pathogenesis. So if you think about, we spend a lot of time and effort in biomedical research to understand how to slow or halt the progression of disease. But salutogenesis is actually the reverse. How do we get the human body back to a healthy state? To build this data set and to overcome these issues, we assembled a team that spanned across the United States with about 7 or 8 different institutions And you might recognize some of the folks on here that have been very active in the retina research field. To build this data set, we made a few structural changes to the way that we're collecting this data to avoid a lot of the issues that I kind of pointed out with the UK Biobank. One is that we wanted to build a data set of about 4,000 people, where about 1,000 of the people will have no diabetes at all, 1,000 will be lifestyle controlled, 1,000 will be oral medication controlled, and 1,000 will be insulin dependent. And within that, 1,000 people will be white, 1,000 black, 1,000 Asian American, 1,000 Hispanic, and within that, one-to-one balancing of males and females. To my knowledge, this level of systematic balancing has never been done at this scale. So there's 3 data collection sites. There's one here in Seattle. Actually, our first participant is finishing up their retinal imaging protocol right now. The other 2 sites is UAB and UCSD. We have somebody in the Native Biodata Consortium that is working with the Cheyenne River Sioux Tribe to see if they might be interested in participating in our study. So what are we actually collecting? So there's, of course, medical history, demographics and vitals, blood work, urine, lots of different surveys, including social determinants of health, cognitive function testing, 12-lead EKG, visual function testing. We're going to do a whole host of ophthalmic imaging because we're retina specialists at heart. And so that includes, color fundus photos, OCT, OCTA, and a newer modality called FLIO from Heidelberg. We are actually trying to solve one of the device dependency problems in AI by collecting color fundus photos on 3 different machines, OCT on 3 different machines, and OCTA on 3 different machines from different manufacturers. We're going to send them home with a Fitbit and then a continuous glucose monitoring device. And we built a custom environmental sensor to measure the air quality inside of their homes. We plan on banking all their blood and hopefully doing whole genome sequencing. But the most important part of this slide is that what we plan to do with this data, we hope to open source it so that anybody in the world can download this data set as long as they have an internet connection. They do not need an IRB. They don't need to go through a data access committee. They can use this data set right away to do research. So we hope that people will do many, many different things with this data set. In fact, I'm not planning on doing very much AI myself with this data set. I hope others will use it. And we have this future goal where any new data that's generated will be deposited back into the open repository, and that people will use the biobank samples to learn more things about type 2 diabetes. So this is our project website, our QR code, if you want to follow along as we go through this journey. And just want to end with acknowledging all the members of my lab as well as my funding sources. Thank you.
Thanks, Aaron. We're going to have time after these first section to ask questions. So just keep your questions in mind, and we'll answer them in a little bit. Our next speaker is Adrienne Scott. She's going to speak on the Viz OCTA, a pulse ox for the retina.
All right, OCT has become an indispensable part of all of our practices, and we're now becoming more comfortable with OCT angiography. Motion capture helps us determine where blood flow is between B-scan frames of the OCT. There is a technology called Viz OCT, and it's been performed since about 2011. It's not new, but certain derivations and innovations in this are new. So this is a novel derivation of the OCT that uses a visible light illumination instead of a conventional near-infrared light like our typical OCT. And we can actually quantify oxygen saturation in the retinal blood vessels. So it is like a pulse ox for the retina. This is fundus. This is a picture of a fundus-based retinal oximetry instrument. We're actually using this in the brain. This is commercially available. But the work I'm going to show you is adapted more so for retinal imaging, and I'll give you an example of the innovations that have been made. So fundus-based retinal oximetry typically had been able to image large vessels. I'm going to show you innovations here from the team that is able to target the macula where the vessels are finer and give us more information about oxygen saturation for those diseases that affect the retina, particularly the macula. We know parafoveal vessels perfuse the macular region, help us with our central vision, and is highly reliant upon circulation and oxygenation. This is an example of the prototype machine. This is kind of big and bulky at this point, but this is the actual machine that's used for the Viz OCT scanning. Here's the device, and basically images are captured from the subjects and undergo a special transformation. And acquisition time is about 2.6 seconds per frame. This is not quick. So if you want to get multiple frames close together, the subject has to have pretty good fixation, pretty good endurance for the imaging. So the way it works is absorption contrast from oxygenated and deoxygenated hemoglobin provides contrast for the oximetry in the visible light range. So it is like a pulse ox, but we're doing it for the retina instead of like a pulse ox you have on your finger. So the shorter wavelength light is in the visible range. You can produce OCT and OCTA images, segment those images and those vessels within the images to create en face images. And saturation of oxygen can be calculated within the vessels. There's quite a bit of post-procedure processing that goes on even after the image acquisition. But we detect structural abnormalities in both the en face and B-scan image and simultaneously get an OCT and an OCTA scan. And we're doing this more and more in the smaller vessels, and after the images are acquired, we're able to extract the oxygen saturation. And I'll give you an example of what these images look like. So this is work taken from a paper by Wong and colleagues that's showing a normal subject. The top two images are, you'll see the OCTA and then the OCT, and you can see the oxygen and oxygen quotient within the venules and the arterioles there. You have the near-infrared image, the OCT angiogram image, B-scan, and then the OCT at the bottom from the Viz OCT. This is your normal image. Here we have a subject with NPDR without DME. You can see the typical capillary dropout, a little irregularity of the vessels, the oxygenation quotient given to us by the visible OCT image. You can see the red for the arteries, the blue for the blue for the venules, the near-infrared image, the OCT angiogram image, and then the Viz OCT B-scan bottom. An individual with central retinal vein occlusion, again, significant non-perfusion, the near-infrared image, an OCT image, and Viz OCT image at the bottom. And then sickle cell retinopathy. This is how I became particularly interested in this particular technology, because it's a really unique disease to be able to study the oxygen saturation of the vessels at any point in time. This is a study that was presented at this past ARVO, and we were able to do a proof of concept and get some pilot data. So we enrolled 10 subjects, 10 normal subjects, to be able to figure out the hardest part with some of these imaging technologies is you don't have a normative database. So you have to generate quite a bit of normative data to be able to know what is abnormal when you image subjects with pathology. Subjects were excluded if they couldn't fixate or for whatever reason there was low image quality. Demographic characteristics were obtained, ocular characteristics such as intraocular pressure, cup-to-disc ratio, and then OCT characteristics such as measurements within the OCT, ganglion cell layer, nerve fiber layer, etc. And this is the oximetry measurements that were extracted from the normals. So again, you can kind of see this is a pseudo-color image, but we are finally getting normative data. What is normal in these normal subjects? About 92% arteriolar saturation, about 48% venular saturation, and then the AV ratio is about 44%. Okay. And there were significant correlations found between the oxygen saturation and intraocular pressure, cup-to-disc ratio, and age, but not the arteriovenular saturation. Another study that was presented in ARVO looked at a disease. I don't want to bore you. I'll talk a little bit about glaucoma, if everybody's okay with that for a little bit. But this is a disease that's really interesting to study with this technology because we know a lot of things happen to precede structural damage that we see in glaucoma patients. So one of the things that we tried to evaluate is measuring macular oxygen saturation in glaucoma eyes and compare them with normal eyes using clinical metrics. So this was a cross-sectional study. We enrolled a cohort of patients who were normal, a cohort of patients who were glaucoma suspects or had pre-parametric glaucoma, and a cohort of patients who had full-blown parametric glaucoma with visual field loss. Characteristics were obtained, including intraocular pressure, visual field index, glaucoma hemifield test, pattern standard deviation. Okay. So other metrics were obtained as well, including whether or not they were cataract, their lens status, their axial length, and of course the measurements of the various parameters on OCT, such as ganglion cell layer thickness. Okay. You can see here the scan is kind of the overall strategy for the hemifield scan, in which the area that was scanned, and we collected arterial and venular saturation in each of these groups. So some of the measurements that were looked at: arterial saturation, venular saturation, the AV ratio of the two as well, and comparing those with any visual field defects that were present on the visual field formal perimetry. So this is a subject with 10 normal eyes, 12 glaucoma suspects, and 13 parametric glaucoma individuals. And we did find a significant change on the eye hemifield O2 saturation between the oxygen saturation in the arterial and venulars in the glaucoma group, particularly in those individuals that already had parametric visual field loss. This is a very small number of eyes. We're not quite sure of the overall clinical utility of this yet, but there's something going on prior to even when you see visual field loss, and definitely loss of oxygenation when the patient actually shows up with full-blown visual field loss. So in summary, this group, and our group at Hopkins, first successfully described and measured macular oxygen saturation using the VIS OCT technology. This is a pilot study, but a start in patients who have normal and glaucoma suspect, and also full-blown glaucoma clinical pictures, and just to be able to get a feel for what the ratio is of oxygen and venular saturation in these various disease states. So the theory here is that we can determine maybe glaucoma and glaucoma risk perhaps before the person comes up with full-blown visual field loss based upon the oxygen saturation. So summary, arterial oxygen saturation is decreased in ischemic retinopathies compared to controls, including those in glaucoma. The technology is limited. It's a long acquisition time, limited by media opacity, patients that can't fixate. Attenuation of the visible light signal is tricky, and it's harder to image more the outer retina, RPE, and choroid. But it shows a lot of promise, and its clinical utility is under investigation. It's probably going to be a nice complement to our traditional near-infrared OCT imaging, and it will give us more information regarding ischemic retinopathies, including diabetic retinopathy, retinal vein occlusion, retinopathy of prematurity, sickle cell retinopathy, and may be helpful for early detection of even macular degeneration in glaucoma. Can also help give us an idea about pathogenesis of the disease before the structural damage happens, and importantly, how the patient is responding to various systemic or ocular therapies as well. I want to acknowledge the group that did this work, particularly Dr. Wang at Johns Hopkins and his mentor, Ji Yi, and the team that contributed to this data. Thank you.
Thanks, Adrian. So another hometown person, Ricky Wang, is going to speak on swept source OCT imaging of CNV and choroid in AMD. Ricky.
And thanks for the meeting organizers for the invitation to speak to the audience. So today I'm going to talk about using the swept source OCT to image CNV and choroid for AMD. And my disclosure, and first of all, I want to thank my team members, and more important, I want to thank my collaborator in BPEI, Phil Rosenfeld, and his team, and also Carl Meditech. Without them, our research is not possible. And so why swept source OCT? So swept source OCT has a longer wavelength, which results in better penetration into the choroid, and it has less sensitivity rule off over the depths. And the longer wavelength affords more laser powers injected into the eye. which will result better signal-to-noise ratio. And also the more power you have will afford you faster imaging speed. So all these advantages compared to spectral domain OCT will give you better image quality in imaging of retina, which is of course important for quantification rather than visualization of the OCT images. And for OCTA to work, so unlike OCT imaging, so OCTA requires repeated scan at the same B scan locations. So for this repeated scan that collapse into one OCTA image, typically 2 repeats or 4 repeats in commercial systems. And to visualize the CMV, the best slab is this slab between the outer retinal layer to choroid capillaries. And this slab gives you best information about the CMV. And so this is, if you have the segmentation software, this is a slab to tease out the CMV information. And so this is projection slab of the ORG slab, so-called ORG slab, so outer retinal layer to choroid capillaries. So in this slab, you will see enormous projection artifacts. So therefore, to visualize or quantify CMV, this projection artifacts has to be removed. So we have the algorithms to do that. In the algorithm, what components is involved in the removal of the projection artifacts. So first one is really, so you need the overlaying retinal structure information, which creates or causes projection artifacts. And so that's the ORG slab with the projection, and also you need structure information of this ORG slab. So plug these 3 components into this equation will give you projection artifacts free image, which gives you the visualization of the CMV and of course to quantify the CMV. And I give you an example for that. So this is an example for RAP lesion, and this is the ICG for the RAP lesion or type 3 CMV. So in here, sorry, can I go back? No, that's okay. So that's the invasive approach. And we use the Plex Elite swab source OCT system to scan one patient over the time. And we scan this patient over the course of 2 years using a field of view 3x3 scan pattern. And in this case, if you look at the ORG slab to visualize the CMV and type 3 lesions, that's going to be very difficult because you have enormous projection artifacts, and you have to remove these projection artifacts. So if you apply that algorithm, that type 3 and the type 1 lesion really stands out. And so this is a 3x3. 3x3 oftentimes is limited to cover the whole lesion, and that gives you difficulty to quantify, right? And the beta slab or beta scan pattern to scan CMV is really 6x6. And this is the 6x6 scan of the same patient over a time course about 1 year. Okay, so you can see the swab source OCT to visualize the evolution of this lesion. Okay, and we have developed an automated algorithm to quantify this CMV, and that really gives you a pretty accurate quantification of the lesion evolution over the time. And that's so the algorithm is not only can be used for quantify the progression of this lesion, but also can quantify the regression of the lesion if the patient receives the treatment. And now comes to choroid quantification. For choroid quantification, you really need to have pretty good contrast in the junction or interface between the choroid and the scleral. And sometimes this contrast is not enough, even you use the swab source OCT. And the way to mitigate that is we use attenuation correction, so-called. And this is really to convert OCT scans into optical attenuation coefficient scans. Okay, and in this case, so we call it OAC correction. Okay, and OAC correction really gives you the ability to automate, automatic segment the interface between the choroid and sclera. And so if you are interested, you can go to these publications to look at it. And so I give you an example of the quantification of the choroid. And this is using the swept source OCT system to scan wide field of the scans. And the scan field of view is 15 by 21. And this is the B scan, and we apply this automatic algorithm or software to quantify the choroid. And because you have the segmentation of the RPE and the interface between choroid and sclera, and then you can have the thickness map of this scan, and this thickness map, and also you can extract the vessel information in the choroid, and this is the vessel map of the vessels in the satellite layer, and of course you can also to have this bigger vessels in Halus layer. And then you have three pieces of information. One is the thickness of the choroid, second is small vessels, and the third is the big vessels. And then you can combine these three together to form this fourth color image, which can give you a kind of information to correlate the thickness with the vessel. Yeah. And I don't know how important is this in clinic, but that's important for publications, right? Yes. And finally, take-home message is that swept source OCT is really excellent to image the CNV and the choroid features. And the outer retina to choroid capillary slab, we call it ORC slab, is best to visualize and quantify CNV. And to quantify the CNV, the projection artifacts has to be removed. And high penetration of the swept source OCT can provide you information about the choroid features. For example, you can measure the thickness and also provides you vasculature information in the choroid. Yeah, with that, thank you for your attention.
Spectacular images. All right, the next speaker in this first section is Alexandra Rachiskaya, speaking on OCTA and diabetic retinopathy.
Thank you, Peter, and wonderful presentation. So we're going to talk about OCTA in diabetic retinopathy, and we're going to take it a little bit to clinic. So these are my financial disclosures. And we all know that fluorescein angiography is a workhorse when it comes to diabetic retinopathy. But I'll be showing you today that maybe OCTA is much more useful than we might think in clinical practice. We all know that fluorescein angiography requires invasive dye injection, and there's potential complications. OCTA obviously is faster and non-invasive. OCTA also provides us three-dimensional viewing, so we can see vessels in different layers, and we can see the associated B-scan with the flow. We can see a smaller field, unfortunately, in OCTA, and hopefully these meetings and such will solve that problem. And also, we can see the dynamic leakage that we can see in fluorescein angiography. So first, we're going to talk about some patients that we see. This is a standard patient that I saw. Overall, looks very good. The OCT looks gorgeous. And of course, this patient is complaining that they can't see. And the reason is because they have this significant area of non-perfusion right in their reading field. And I have the 3x3 and 6x6. And you can always show a normal to a patient to educate them as well. So non-perfusion has been studied extensively and has been shown to correlate with visual acuity. And interestingly, when we look again at FA and OCTA, we can see that OCTA does much better in terms of detecting this capillary non-perfusion when you compare it to wide-field fluorescein angiography. We also were hopeful that our treatments, such as anti-VEGF, might actually change things in terms of non-perfusion, and it's been shown that there is no change in capillary non-perfusion and then no reperfusion of the small retinal vessels in those areas. Sometimes it is challenging when you look at OCTA and you see diabetic macular edema that might appear as non-perfusion. And the difference is that when it comes to diabetic macular edema, it appears completely devoid of flow and are more oblong in shape as compared to areas of non-perfusion, and has smooth borders and does not follow the distribution of surrounding capillaries. We talk about different treatments for our patients with diabetic retinopathy, and sometimes it's important to predict who are the patients that are at risk of progression. And this is one study looking at patients who were treatment naive, moderate, or severe NPDR, and looking at the deep capillary non-perfusion, it showed that they were those who had more significant deep capillary non-perfusions were at higher risk of progression at 1 year, looking at development of diabetic macular edema, need for PRP, and need for anti-VEGF treatments. So I showed you non-perfusion. So moving on to this patient who has partial PRP, and we can see here, of course, this patient who is much more in trouble than the first patient is 20/20 and has no visual complaints. And when we look at this OCTA, this is a 12/12 that I utilize routinely in clinic when I look at patients with diabetic retinopathy. We can see that he does have very nicely perfused foveal region, but outside of the macula, there is significant non-perfusions with areas of neovascularization. And I think this interface is very nicely allows us to see the areas of neovascularization, and usually this I use the B scan to look at the flow. And I think we're learning a lot too, because you can see this area of traction in the area of neovascularization, and the question is, are we able to identify patients who might be, for instance, be at risk for a crunch phenomenon when you have neovascularization in the area of traction? And as you know, you can image other areas as well. This is 8x8 focused on the optic nerve. And I find that in clinic, I'm not a big fan of vitreoretinal interface because I think it's harder to assess it, but you can immediately look and see the areas of neovascularization. This is the fluorescein angiography of the same patient, and as predicted, we can see significant non-perfusion and areas of neovascularization. But my question to you is, do we really need the FA on this patient, and would your clinical decision-making be different if you had just 12/12 OCTA in a patient like this? This is another patient who has a pretty benign-looking fundus photo. And you can see some non-perfusion peripherally, some maybe mild leakage, but not a very impressive fluorescein angiography. And if you obtain a 12/12 OCTA on this patient, you can see this area of neovascularization of the nerve. And if you look back, you can kind of see it again here on fluorescein angiography, but it's much clearly seen on the OCTA. And once again, this might change your clinical treatment of this patient. You might potentially see this patient more frequently or even initiate treatment. So when it comes to neovascularization, this was a nice study looking at OCT and OCTA in PDR. And when looking at the studies, because we use different imaging modalities, we use different OCT and OCTA machines, it's important to look what exactly was looked at. In this study, the OCT scan was 12 millimeters, whereas the OCTA was 6x6, which was either centered on the fovea, on the nerve, or you could image your area of interest. So they looked at the detection of new onset NVD and NVE, and they saw that for new onset, the structural OCT had the highest detection rate. But once again, remember, it's a 12 millimeter scan. However, when they looked at the detection of regression or reactivation of neovascularization, B-scan OCTA had the highest detection rate, whereas the structural OCT detected regression only in 45.5% of cases, and a rate of reactivation was 12.5%. So now I pose you another question. Do we really need our regular structural OCT if we can use OCTA, a 12 by 12 OCTA scan that will show you the DME, it will show you areas of non-perfusion, it will show you areas of neovascularization in terms of both regression and reactivation. And this is another nice ability of OCTA to look at IRMA versus neovascularization elsewhere. So we have this FA, and we've all looked at these FAs where there is some haziness and potential leakage. And when we do the OCTA, you can clearly see that in this patient, this is IRMA versus not NVE because it's confined to intraretinal flow. There is no outpouching or breach of ILM. And this is another patient in whom you can see that this is neovascularization elsewhere, as you have the supraretinal flow with breach of ILM and the posterior hyaloid on flow overlay. And sometimes these are challenging. Once again, if I look at this FA, it's sometimes hard to say if it's truly an NVE, and obtaining OCTA in that area, you can clearly see that there is no breach of ILM and the flow is intraretinal. And this is another case where there is, once again, a leakage that potentially seen on FA, and you can see that there's very early NVE on this OCTA. There's also a lot of work trying to actually analyze the NVE in much more detail than we've previously have using fluorescein angiography. There's potential classifications such as type 1 originating from the venous side in a tree-like shape, type 2 originating from the capillary network with an octopus-like appearance, and on the bottom, the type 3 originating from IRMA having a C-fan shape. And I think a lot of work still remains to be done in this area because I think these areas of NVE are not all created equal. We see this kind of fuzzy appearance of NVE, but then NVE associated with traction. And sometimes this is kind of what it usually looks like, but sometimes you get these more mature vessels, and it's interesting to follow these patients and see what the clinical significance of this might be. NVD is also very different. This is kind of a standard NVD when it's coming out into the vitreoretinal interface. But in this case, you have a very flat neovascularization of the disc that might be behaving differently and having different clinical implications for these patients. And I'll just finish with this case that I saw the other day. This patient kept bleeding, and I think it's a very beautiful PRP, probably done by Dr. Cox, who is sitting here in the front row. But the patient continues having vitreous hemorrhage. And you can see that there's some non-perfusion and not really, though, leakage. And, but the patient is constantly bleeding. But FA doesn't give us a clear answer, whereas here you get OCTA and you can see the area of neovascularization on the disc. And once again, that might inform how I treat this patient. I thank you for your attention and the opportunity to talk about OCTA and diabetic retinopathy. Thank you.
So I'm going to open the floor for any questions on the talks that we just had. Please.
And the macula is very important in relation with the progression of glaucoma. But there are theories that talk about the fact or the point where the damage takes place is at the border of the optic nerve, and it affects the vessels that kink and bend. Do you correlate the saturation of those capillaries with those of the macula?
The work is very early. I think that's a great thought to be able to correlate the peripapillary vasculature with the macular vasculature as far as incidence of glaucoma or where the first damage occurs, which area is most sensitive to show the earliest damage. So that's a great area to look into. We don't have that data yet.
So my question is also a question on the oximetry. So looking at the retinal function, so some part of the outer retina is supplied by the choroid. So I wonder if you take cognizance of this into your research.
Yeah, interestingly enough, this technology is certainly most sensitive and demoed in the inner retinal vessels. So unfortunately, one of the limitations is the inability to really get robust imaging of the outer retinal oxygenation and choroid. So the deeper we go, we have less information about the disease process.
So Alexandra, those images were beautiful. Is it time to ditch fluorescein now that we can't get fluorescein anyhow?
Yeah, and please, I don't know if we're giving a talk on fluorescein at ASRS.
Yeah.
But I think in the clinical practice, it's really changed my kind of thinking in the protocol. So I routinely order OCTA in my diabetics, and there's some patients some patients you might not catch because the non-perfusion is too peripheral for OCTA to catch. But in a 12 by 12, if I see in areas of neovascularization non-perfusion, I know what to do. So I don't need to subject those patients to fluorescein angiography. And there's whole debates about fluorescein and kidney disease and dialysis patients, and it just makes it much easier in the clinical flow. But I don't think fluorescein is dead by any means, and I think there's definitely patients who benefit in terms of deciding how to treat them.
Ricky, your images and your algorithms are incredible, but a lot of them are based on a swept source, Carl Zeiss swept source. Do you think any of those algorithms will trickle down to the OCTA machines that many of us have in our offices, not swept source, or is it really only swept that can do this?
It's not necessary. Doesn't work. It works. Okay.
We can hear you.
It's work. Yeah, so actually we're working towards the spectral domain quantifications. But the spectral domain, as you know, that works at shorter wavelengths, 840 nanometers or 850 nanometers, which really gives you pretty high scattering property at the RPE complex. And so that RPE complex really stops the light going deeper into the choroid. So in this case, so to quantify the choroid features using the swept source OCT, some cautions needs to be paid. And oftentimes you need to have the quality check software, and some quality check software is available from a couple of groups, right? And that's important to quality check of the scans in the SDOCT systems, particularly for the choroid quantification.
All right, so unfortunately, Dr. Saraf, if you were hoping to see and hear him, because he's an amazing lecturer, had a personal emergency, and he unfortunately won't be at ASRS. So Dr. Dan Martin has agreed to pinch hit, and he's going to make his DRCR talks into part 1 and part 2, which probably was good anyhow, because it would have been a part 1 and 2 anyhow.
Yeah, that's right. Thank you very much, Peter. Yeah, I'm not an equal trade for David. He has a lot smarter things to say than I do. The first part of this is going to be really directed more towards the fellows and hopefully be a review to basically talk about the network. As you all finish and go into practice, I seriously hope that you will consider joining the network, because the first part I'm going to talk about, I just picked 5 studies that all of us know. You've all seen parts of it. I hope to give you a little more insight into some things maybe you didn't know about these trials. And then the second part of this talk is going to be about the stuff we're doing now and the stuff, my assigned topic, which was the 5 things I'm excited the most about from upcoming DRCR trials. I have no financial interest. So some of you have seen this slide before. Network was founded in 2002 as the Diabetic Retinopathy Clinical Research Network. 2017, they allowed us to expand our scope to study all retinal diseases. We renamed it the DRCR Retina Network. DRCR no longer stands for Diabetic Retinopathy Clinical Research. It's like KFC and Kentucky Fried Chicken, right? It's just KFC, right? It's DRC. It's its own little noun, so to speak.
Kentucky Fried Chicken anymore?
This is KFC. That's right. So the JDRF. So the Juvenile Diabetes Research Foundation is no longer called the Juvenile Diabetes, it's just JDRF. So we are now the DRCR Retina Network. We've conducted a lot of trials, completed 36 of them, 100 publications. This is our structure. There's 1,800 members of it. I have the incredible privilege of serving as one of the 2 network chairs along with Jennifer Sun. She's amazing. Love working with her. Adam Glassman is the biostatistician along with a whole host of other biostats people. And we spend a lot of time exploring new ideas. Most of them never lead to a trial, but the ones that do turn into trials wound up usually being pretty good. We've completed 36 studies, and so I just picked out 5. And we'll start with an old one. You all know this, Protocol I. This is back in the Stone Ages. This was their very first trial that showed that anti-VEGF therapy was effective for diabetic macular edema. And that wasn't the surprise here. To me, this was the most important finding from the study, the thing that even to this day shapes how I think about these patients. I don't think anybody expected this, and that was that the need for the injections decreases over 5 years. In the first year following the DRCR protocol, you need 8 to 9, and by year 2, you only need 2 to 3, year 3, 1 to 2, 0 in year 4 and 5, i.e., diabetic macular edema is a self-limited disease. And I don't think I ever fully appreciated that when I was picking off microaneurysms with lasers, doing focal laser, doing grids, and being incredibly frustrating how poorly this worked. And all of a sudden you look 3 or 4 years later, it's like, oh, a lot of it was gone. Turns out it is a self-limited disease. And so it becomes about preserving vision during that period of time. Not always self-limited, but it can be. And this shapes a lot of the protocols that we did. For example, Protocol V. This really comes into play there. And I'll come to that in just a minute. So number 2, Protocol T, you all know this, that basically Eylea did better aflibercept did better than ranibizumab, did better than bevacizumab for people who are 20/50 or worse. But in the subset in the patients who were 20/40 or better, it didn't matter which one you started with. This trial and the 20/50 or worse data has led to this idea that there's this giant difference between the anti-VEGF treatments, and yet there's less than a lot of people think. If you look at the proportion of patients who had a 15-letter difference at 2 years, the absolute difference between the proportion of patients who had a 15-letter gain with aflibercept was 58% versus 52%, only a 6% absolute difference. And which was the genesis why we did Protocol AC, which we published in the New England Journal 11 months ago. A lot of people think we did this trying to prove step therapy. I will say from the outset, no one in the network wants an insurance company to tell us what to do. Nobody does. We hate it, right? But the reality is we are being told what to do. And the reality also is that more than half of people 20/50 or worse still wound up with very good vision using bevacizumab only. So because this was being imposed on us, we decided we should study this. So this is 312 eyes, 20/50 or worse, with diabetic macular edema randomly assigned to aflibercept monotherapy, or starting with bevacizumab first with an allowed switch to aflibercept using pre-specified suboptimal response criteria. The primary outcome was mean change in visual acuity over a 2-year period, and specifically we did the area under the curve. And what you see here is that there was no difference between the two, starting with bevacizumab and allowing people, the proportion of people who did not have to switch, the people who did not do well switching to aflibercept, there wasn't a permanent vision loss from starting with bevacizumab, which was, a lot of people honestly wanted this to fail. A lot of people wanted to use this data to say we shouldn't be doing step therapy. We really didn't want to give insurance companies the more ammunition, but the data is the data, right? There was no difference in visual acuity at 2 years, either 20/20 or better, 20/40 or better, or 2200 or worse. No difference in change in visual acuity, not even, there was nothing. Everything we looked at. Now, one of the things that was interesting in this trial was that the majority of people who were treated with bevacizumab first did switch. 60% at 1 year, 70%. So 2/3 wind up switching, but realized that using the same criteria, about 1/3 of the patients assigned to aflibercept also would have switched, but they couldn't switch in the trial. We did a cost analysis that I presented at the Macula Society last year and is being presented by Matt McCumber here at this meeting because still trying to find, was there something in this data that we're missing? Was there something that we were hurting patients by starting with Avastin in these more severely affected eyes with diabetic macular edema? And the answer was no. As you can see, the lines are completely superimposed. This is a measure of utility over time of the better seeing eye. These are the number of QALYs, and there was no difference at all. When you look at the cost effectiveness of this, obviously starting bevacizumab first was much less expensive, and when you look at the incremental difference, the ICER, the incremental cost-effective ratio, was $837,000. That's not a real number. But it gives you a number. What you're looking for, was it below or above $100,000? In general, ICERs that are below $100,000 are considered cost-effective, above or not. And using the same data, and please forgive me to my Regeneron colleagues in the room, what I'm about to show you, I'm not suggesting that EYLEA should be $305, but if you want to make it cost-effective, that's what it should be, at least according to this data. I put this slide in here for a reason, and that is I've talked a lot about systemic adverse events, forever. You may recall in CAT there was this difference that people tried to blow up, and we said it was probably chance. You may remember in Protocol T there was a increased risk of adverse events against ranibizumab, and in the New England Journal editorial that I wrote, I said that's almost certainly chance. And here you have it here. Again, this time it's against aflibercept. You see a statistically significant increased rate of hospitalization, serious adverse events, and hypertension against aflibercept. That's not real, okay? My point is that this is just chance. And how could it be? Because 2/3 of the people switched. So I show this really hopefully to teach the fellows, when you see these trials and you see these differences in adverse events, and that may come off as statistically significant, if they don't make any sense, just take it with a grain of salt. Because in this case, it has to be chance. There's no trial that's ever shown that there's an increased risk of these things with aflibercept over bevacizumab. If you're looking at hundreds of thousands of patients, it's a different thing. But if you're looking at these small trials, you see this kind of weird stuff all the time. And I have spent 30 years, 35 years doing clinical trials and seen this stuff a lot. But every time it comes out, people just go kind of crazy. They think it's real. It's not. Okay? Sometimes it could be, and you want to be sure that it's not. And you don't want to be responsible into taking a hard look at it. But this one, here's a great example where 2/3 of the people, both groups mostly got the same drug, and you're showing a difference, right? It's a nice example of the role that chance plays in these trials. Number 4, Protocol V. We published this in JAMA in 2019. These were eyes with diabetic macular edema and good visual acuity. So this one kind of goes back to Protocol I. I showed you that DME becomes a self-limited disease in a lot of patients. And so the question is, in people with good vision, do you really have to treat that? All of the trials that had been done at that point were 20/32 or worse. No one had ever looked at this group of patients who walked in the door with diabetic macular edema and OCT, sometimes very impressive, and the visual acuity was good. By the way, anybody in the room know what the correlation between OCT thickness and visual acuity is? It's terrible, 22%. The predictive value of thickness on OCT is a very poor predictor of visual acuity. You can have OCTs that are 500 microns thick and they're 20/20. This is why the FDA has never allowed OCT parameters to be used as a primary outcome in a clinical trial for FDA approval. It's because of that. So you have the patient who walks in with impressive diabetic macular edema, 20/25 or worse, 20/25 or better. Should you treat? Most of us were, because we didn't know. This trial looked at that, and I'm very quick to skip through this because I think you all know the results. But basically, all 3 groups wound up exactly the same. Those treated with aflibercept, those treated with laser, and those treated with observation. There was some switching that took place, but it was in the minority of cases. And what was really interesting is that in the observation group, 63% of those patients never received an injection and still had resolution of their disease. So number 5 was protocol W, which looked at the anti-VEGF effects on diabetic retinopathy and its complications. You recall Panorama showed very nicely that there was a reduction in vision-threatening complications, and indeed there was. And in the 2-year results for protocol W, we showed the same thing. 399 eyes, patients treated with aflibercept monthly times 3, then Q4 months versus observations, primary outcomes, development of PDR or center-involved diabetic macular edema with vision loss. And we also looked at visual acuity. Sure enough, the expected difference that you would see, that if you look at the proportion of people who developed proliferative diabetic retinopathy or center-involved diabetic macular edema, those who were treated with aflibercept versus sham, the aflibercept eyes had less of these vision-threatening complications at 2 years and at 4 years. And most of it surprised me. I really thought most of this would be diabetic macular edema. It was proliferative diabetic retinopathy, but also there was a difference in center-involved diabetic macular edema, and it was statistically significant. The cohort behaved like we expected it to. This is on the left, you'll see increasing severity of diabetic retinopathy. By the way, for the fellows, if any of you are interested in knowing where these numbers come from, level 43, 47A, 47B through D, and 53, it's almost impenetrable, understanding sort of what that is. But Denny Davis created this whole thing. I know exactly where it came from. I spent a lot. I'm one of Denny's disciples, and I can tell you exactly how this came to be if any of you are interested. But we'll do that offline because I don't have time to go through it. Okay, but basically you'll see that with the increasing severity of disease, you see the increasing development of PDR-CIDME. That's an important sort of check. Did the cohort behave exactly as you expected it to? And it did. But when you look at the whole thing, basically, there was no difference in visual acuity. So there was the take-home findings from the 4-year data, Protocol W, published in JAMA just last year, was that while it does reduce vision-threatening complications, it does reduce PDR, it does reduce DME, it makes the retina look prettier. I skipped over that slide, does that very nicely. That versus doing that versus treating before these things happen versus waiting for disease to occur, there's no difference in those two. And here you'll see the visual acuity differences at 2 and all the way out to 4 years. There was nothing. So with that, I'll stop, and I'll do the second part of the talk in just a bit. Sorry, this is an imaging session. This really wasn't about imaging, but I thought it'd be a nice review and kind of a nice setup for what we're going to do in the second part of this talk, which does get into a number of protocols we're doing now that handle some imaging. Thank you.
Amazingly, we were on time despite January.
Maybe. These are my financial disclosures. I do work as a consultant for multiple dry AMD companies and also have research funding from many as well. So when we look at the next frontier really for dry AMD therapeutics, we're entering really into a new era where we have management options for us, which is incredibly exciting. And understanding risk stratification and optimizing personalized care is really going to be important. As we know, imaging is really a staple of what we do as retina specialists. And when we look at the way we've used imaging, it's often been changes in new therapeutics that have driven changes in the way that we use imaging in our clinics on a day-to-day basis. And for dry AMD, that time is really now. And how our imaging protocols have been in the past may now need to adapt or change to better suit what we need as clinicians with these new and emerging treatment options. So when you think about the imaging modalities for dry AMD, they're really kind of the key ones that we've heard about already: fundus photography, fundus autofluorescence, OCT, FA, and OCTA. I'm going to do kind of a whirlwind tour through these. Fundus photography gives us great objective information regarding severity of retinopathy, and it's useful for monitoring disease progression and for communication. Looking at disease over time can be really helpful, and certainly has applications for telemedicine and remote diagnostics. We're seeing less and less utilization of this. It is non-invasive and a quick image, but it does require pupil dilation. It's unable to be billed on the same day as OCT, and digital technology has dramatically enhanced the flexibility of these systems, including portable solutions and AI system integration. What about fluorescein angiography? Well, this was really, if you go years back, the gold standard for imaging in retinal disease management. Typically, we think of this as using IV injection of sodium fluorescein and provides functional information related to retinal and choroidal vasculature, including leakage, non-perfusion, and staining. But there's really been a significant reduction in utilization of FA, particularly for macular disease. So where do we use it in FA for dry macular degeneration? Well, generally it's relatively uncommonly used without evidence of exudation, may demonstrate staining of drusen, window defects, and areas of atrophy. And as we see new therapeutics emerging, it also can be important when we look at potential complications, particularly using ultra-wide field angiography. We also can use it to look for choroidal neovascularization, but OCTA can also be helpful in those cases as well. Fundus autofluorescence is really one of the things that we think of as a gold standard in terms of the imaging that's used for dry macular degeneration. There's some key characteristic changes. It can confirm the suspected diagnosis. And really where we see it most useful is in cases of geographic atrophy. We may be able to explain vision loss, such as identifying subtle subfoveal atrophy. But one of the key things is it may not be widely available, and particularly if we have multiple offices, it might only be available at one office. And so the question is, what's its role, currently for us? When we look at the clinical trials that are used, this has historically been that gold standard. And when we look at our current phase 3 trials for the drugs that are available, the drug that's available to us now and potentially others in the future, it's really fundus autofluorescence that's being used as the benchmark. And there's been different features over time that Frank Holtz and others have identified that are linked to progression risk factors, particularly around the hyperautofluorescent patterns in the junctional zone. We see here this clear dark area of geographic atrophy with hypoautofluorescence with no real significance surrounding fundus autofluorescent areas, where here we see this focal areas of hyperautofluorescence, and then here this banded pattern. And these specific patterns can change the overall risk for progression, and many of these patterns have been used as inclusion factors within many of the clinical trials to particularly identify those patients who may be at greatest risk for progression and may benefit from treatment. The diffuse trickling pattern has also been particularly associated with progression risk. Interestingly, there's some unique findings, including this kind of less dark atrophy in these eyes and a separation of RPE Brooks membrane that we can see on OCT when we do OCT fundus autofluorescence correlation. The other thing that we see is that as technology continues to progress, there's opportunities to actually quantify fundus autofluorescence, which may also provide greater insight and personalized phenotyping. What about OCT angiography? We heard and saw some amazing images earlier from some of the talks. This continues to be an emerging modality, particularly with our spectral domain systems. Ricky mentioned some of the real challenges that we have in visualizing some of the choroidal features in these eyes. And some of the key things that I think of in terms of dry macular degeneration is looking at, for non-exudative, for example, CNV. And this provides this nice structural, functional feedback based on what we see. When we think about some of the potential prognostic features that we can get with OCT angiography, the choriocapillaris has been linked and work done by Phil Rosenfeld as well as by Voss and others have shown that these flow voids, particularly at the edges of atrophy lesions, may be linked to progression. We can see here in the top row, here in this eye, we see a geographic atrophy lesion really doesn't change much over time, and the choriocapillaris pattern is relatively uniform, whereas in the bottom we see rapid expansion of the geographic atrophy with these flow voids at the edges of the atrophy lesion. But this does really pose challenges in terms of imaging consistency as well as our ability to analyze this. And this brings us to OCT, which really is the workhorse that we use for the vast majority of the retinal diseases that we manage on a day-to-day basis. And it provides extensive information for us in terms of the structural disease burden and retinal alterations that can be there. And over time, we've seen multiple different features that many groups have identified that may have important prognostic features for geographic atrophy development as well as geographic atrophy growth. I'm going to run through some of these. Cindy Toth and the group at Duke were some of the first, first research that was done to look at drusen features and how these drusen features may change overall prognosis and risk for progression to atrophy over time. When we look at this, the drusen reflectivity of the substructure may be important. So, for example, hyperreflective drusen cores may be more at risk for progression to atrophy than those that don't have this hyperreflectivity, as well as when we look at overall drusen volume may be linked to progression as well. This was shown in the AREDS A2A study, and has also been shown in multiple other studies as well, that overall this link that we can have with drusen burden may be an important prognostic sign when we look at eyes at greatest risk for progression. Retinal hyperreflective foci has also been shown to be clearly linked to overall disease risk and progression to geographic atrophy. This has been seen in multiple different data sets and is an important thing to be looking for in your patients for risk to progression to geographic atrophy. More recently, we've also seen persistent hypertransmission defects. Phil Rosenfeld has really championed this as a potential important new clinical trial endpoint that really occurs based on reduction of the attenuation that's seen as we see progressive outer retinal atrophy and RPE loss. This can be recognized both on the en-face OCT, but also at the B-scan level. One of the nice things is now we have technology to be able to do this in an automated fashion and not just have to be able to measure this solely manually. So when we look at this, really, we've run through a bunch of different features for progression risk. Voss and Charlie Wyckoff published a recent study where they looked at this in 300 eyes of what was greatest risk for development of C-RORA and really reinforced that many of these features can be really important in progression risk. The last thing I'm going to talk about is outer retinal integrity, which also provides a unique opportunity with some of the machine learning technologies and our segmentation availability that's here, particularly focused in the ellipsoid zone integrity and photoreceptor integrity. Dan mentioned the lack of correlation between central subfield thickness and visual function, and one of the key things here is that ellipsoid zone integrity has been strongly linked to visual function in multiple different diseases. We now have the ability, using different technologies, to compartmentalize the OCT of where we think things are most important. And we can see here, this is an eye with intermediate AMD, and that ellipsoid zone integrity map shows significant loss of photoreceptor integrity. And just 2 years later, we see dramatic development of geographic atrophy in the area of photoreceptor loss. We see this is an example of a non-progressor over that same time. And when we look at this in a machine learning classifier, it's really some of these quantitative features that are most predictive of progression and may be important going forward. One of the big questions is, can we apply this in clinical trials? Can we look at this in our patients who are sitting in front of us? And one of the exciting things is we're seeing this in multiple different studies that we can now measure this. This is from the STEALTH RECLAIM 2 phase 2 study showing reduction in progression of photoreceptor loss. This is work by Ursula Schmidt-Erfurth in the Oaks and Derby showing significant reduction in photoreceptor loss with pegacetacoplan. And similarly here in the GATHER1 program showing reduction in photoreceptor loss based on ellipsoid zone integrity as measured here. And so this really overall is an exciting opportunity, and one of the things that we've now heard from the FDA is this may be an approvable endpoint that can be used going forward in dry macular degeneration. The last just brief thing I want to talk about is actually going to pure machine learning. These are all things that we can either see qualitatively that I've talked about before or in segmentation. And an idea being, can you use machine learning to enhance visualization of some of these risk factors, including ellipsoid zone loss? This was a model that we developed to look specifically across spectralis and cirrus systems for loss of ellipsoid zone integrity and risk for progression over time. And to develop this, that you can actually overlay this with segmentation technology to have things such as at-risk drusen. This is an example here at year 0. In this top row, we see ground truth geographic atrophy developing at year 3, as well as growing at year 5. And that middle row shows the area where the machine learning technology is looking at the B scans and identifying areas at greatest risk. And 3 years later, we see that geographic atrophy developing into those areas that are at most interest to the model. We see that this is really a hot area. Multiple groups have been able to look at machine learning and the potential risk of GA growth over time, and this is really going to be an exciting area that we look at and how we can better personalize care for patients going forward. So in conclusion, there's really a tremendous wealth of information in our imaging that we use on a day-to-day basis. How we use this is one of the things we're going to talk about in our next panel. And emerging technologies, both in terms of devices, but also on the software side, will really be critical to help us understand both biologic relevance of the disease, but also how we can pair patients with the right therapies. So I want to thank you again for the opportunity to speak today, and thank you for your attention.
Thanks, Justice. Voss Sada is now going to speak with us. Voss is going to talk to us about high-resolution OCT and AMD. Peter said that I was going to inherit some of my colleague David Seraf's time, but I fear that Dan Martin may have absorbed all of that in his presentation. But if at any event, these are my disclosures. So first of all, I thought in a presentation like this and talking about high-resolution OCT, we need to define first what we mean by high resolution. Of course, with OCT being a three-dimensional imaging technology, we could potentially enhance the resolution in different dimensions. We can first start talking about improvements in transverse resolution. And of course, Ricky Wong gave a brilliant talk about swept source OCT. And with these devices, we're able to scan very rapidly. And so we're able to do these very dense isotropic scans, get megapixel, essentially en face OCT volumes. That can be very helpful, I think, for understanding various different, I'm not sure if this is going to play or not, but different entities such as outer retinal tubulation. I'll say more about outer retinal tubulation in a moment, which I think gives a superior detail compared to the standard resolution we achieve with typical spectral domain devices. So if we want to improve transverse resolution even further, though, you really have to be able to create a smaller spot on the retina with the laser. And to do that, you'd have to actually compensate for the aberrations inherent in the optical system of our eyes. And this is where adaptive optics, which I think most here are familiar with, comes into play. So I want to switch, though, from improvements in transverse resolution to trying to improve axial resolution, which is really the main focus of my presentation. And we know that most of our commercial OCT devices can yield axial resolution in the order of 6 to 7 microns. And historically, if you wanted to go to finer levels of resolution, you'd have to use pretty expensive light sources such as titanium sapphire systems. But of course, there are opportunities to do this by multiplexing SLD light sources as well. And this is actually something that Heidelberg recently did in a prototype device that I'll talk about. Again, axial resolution OCT depends on two things. It depends on the wavelength of the light as well as on the bandwidth. And so if you increase the bandwidth of the light source, or reduce the wavelength, you could potentially improve axial resolution. This is just sort of a comparison. I don't know how well it's coming on the projector, between comparing high resolution, maybe on the blow-up image is easier to appreciate the differences between high res and standard resolution OCT. But maybe the holy grail is applying both adaptive optics and improvements in axial resolution, so you get the benefit of both transverse and axial resolution improvements. The far left is a Canon prototype AOCT system, but again, you can appreciate the improvement, I think, in the visualization of outer retinal bands even achieved with standard or with high resolution OCT without even the aid of adaptive optics. And really, again, we think of OCT as giving us almost a histologic-like biopsy, and it seems like we're getting closer and closer as we improve the resolution. Now, I want to talk in particular, I'm going to focus on some of the features that Justice pointed out in his presentation, but one of the things we've started to realize is that when you do higher resolution imaging of the axial dimension, you can start to resolve this interesting appearance of retinal capillaries just because of the flow performance. You see this kind of snowman-like or hourglass type of appearance. You can appreciate that kind of bilobe appearance of the capillaries. And that I'm going to show you can be useful for differentiating capillaries from other structures of interest, such as hyperreflective foci. Now, the improvement in resolution also starts to allow us to see a variety of additional structures in the eye. Justice's lab has done brilliant work in segmenting outer retinal bands, but Justice, you have a whole lot of additional bands to segment here now as we start to appreciate subcellular layers as well. In addition, I highlighted the MLM there. That's the elusive middle limiting membrane, which is the synapse between or location of the synapses between the photoreceptors and bipolar cells. And that's obviously something we typically don't see with standard resolution OCT. So I really want to focus, though, on how this can actually be, this is all nice, pretty images, but how does this actually impact us in our assessment of our patients in clinic? In particular, I want to focus on these AMD biomarkers, and I thank Justice for already introducing this topic very nicely. And there, of course, have been a number of different biomarkers that have been reported over the years. Hyperreflective foci in particular, I think, is a very interesting one. When we talk to patients about this, we tell them, well, boy, those RPE cells must be so unhappy. They left the monolayer seeking greener pastures. So that's a way of thinking about why this is a bad feature. And I look at that when I see patients with that sign. I talk to them differently because I know that's an eye that's in trouble. And in fact, study after study has demonstrated that all of these different biomarkers that Justice pointed out are important, but hyperreflective foci consistently come out as the most important predictor in terms of risk for progression to advanced AMD. And these hyperreflective foci, of course, have a very characteristic appearance, but you can appreciate that, that there are a whole bunch of little hyperreflective dots that I've highlighted in this standard, pretty good quality OCT image. And what we can see with comparing conventional high-res OCT, this is obviously a highly magnified image, is that with high-res OCT, some of these bright dots you actually can resolve and see that they split into this sort of hourglass, sort of snowman type of appearance. Those are actually retinal capillaries, and we found indeed you can confuse. This is just another illustration to show these lesions and how one could very easily confuse some of these, especially when you're talking about hyperreflective foci that have migrated to the internuclear, how you can confuse them with the retinal capillaries. And this is just a side-by-side comparison of conventional and high-res OCT, and you can look at the yellow arrowed structures and see that differentiation that you can achieve with the improvements in axial resolution. Now, another risk factor that's been shown to be an important biomarker are the presence of subretinal drusenoid deposits. And there's actually a staging system for these lesions. In stage 1, they're barely appreciable above the RPE band. And you can imagine with standard resolution OCT, they may not be that easy to see when you're just at that stage 1. And in fact, that is the case. And in fact, we've observed that with high-res OCT, we're able to appreciate and pick out many more of these very early stage SCDs. And as you monitor these patients over time, you see them progress to the more advanced stages. Another risk factor that Justice also highlighted was the presence of a substantial drusen load or a high central drusen volume. And certainly you get a better rendering of drusen using high-res OCT. In fact, if you want to separately isolate the drusen volume compared to the RPE band and Bruch's membrane, it's much easier to do that, as you can imagine, when you have improved axial resolution. I want to also spend a moment to talk about looking at atrophy using high-res OCT. And the CAM group, we came up with this OCT definition for atrophy, which was based on identifying specific features, the presence of this type of hypertransmission, a zone of disruption or attenuation of the RPE band, and then overlying evidence of photoreceptor degeneration. And if you had a certain size, 250 microns, we said, the reading centers came together and said, yeah, we can do that reliably, and that became the definition of C-RORA. And then if you had these features, but maybe it wasn't quite 250 microns, so even the reading center would project that maybe this was harder to do, then you essentially had IRORA, or incomplete RPE and outer retinal atrophy. And in fact, these endpoints we think may be of some value. Both pegcetacoplan and avicent captad in post-hoc analyses have suggested that they may show a slowing of the rate of conversion from IRORA to C-RORA. So looking at these endpoints may be of some interest. But the challenge is that it's not so easy. In fact, when we looked at the reproducibility of 6 different reading centers, multiple graders, to judge these parameters, we found that, yeah, many of the features they could do quite well, but they really struggled with things like the assessment of the RPE disruption, especially when you're looking at relatively small regions. So in fact, this is where I think high-res OCT can have a real benefit. We have a paper that's under review on looking at these features and the potential improvement that we see with high-res OCT. But basically here you can see how brilliantly Bruch's membrane is resolved, and you can see those little RPE cells kind of just extending past the edge. And you can imagine how difficult that would be with standard resolution OCT to make these determinations. So that certainly is proven to be a boon for graders. This is looking at just more examples, again showing the very high contrast and ability to resolve Bruch's membrane in a patient. We imaged this patient both with standard resolution and high-res OCT. And I would say the standard resolution OCT looks pretty good. I mean, that's pretty much what we get in the clinic. But there is an enhancement with a high-res OCT. This is another patient with a hyperreflective drusen core. And this is just another example showing rendering of outer retinal tubulations with high-res versus standard resolution OCT. But really call your attention to, again, the appearance of Bruch's membrane. When you're looking to see is RPE preserved on Bruch's membrane or not, having that resolution we found to be of benefit. Lastly, I'll talk about neovascular AMD and is high-res OCT of clinical value. We classically talk about this entity of double layer sign, and Robin Geimer sort of reclassified this and recommended the term shallow or regular RPE elevation, or SIRE, right? So that's what these lesions are called. And the question often comes up, are these SIRE vascularized? And as we saw in the previous presentations, the best way to determine this really is with OCT angiography. But we all know that that may not be available in every office. And we know that when you see these areas of RP elevation, they're very sensitive for detecting type 1 neovascularization, but they're not necessarily specific because they don't necessarily have to be vascularized. But it does make a difference in deciding whether they're vascularized or not, because we know that when you have this type of a Sire lesion, these eyes are at higher risk for conversion to exudative neovascularization. So when we spot them, we have the patient come back sooner. We might have them come back in only a couple of months. So this is a clinically relevant determination to make. And as I said, you can have shallow elevations of the RPE, like in this example here, which may not be vascularized. And this may be just the accumulation of basal laminar deposit. So these areas of thickened basal laminar deposit can produce these very shallow elevations as well. And we coined this term thin double layer sign when we only saw in this example here, you see like a thin kind of grayish band between the RP and Brooks membrane there. When you see just a single band of reflectivity, not multiple different layers, we call that a thin double layer sign. So the term thin had nothing to do with the actual thickness. It was actually just based on the number of layers of reflectivity. And it's important because in a recent paper, we demonstrated that, yes, all those different risk factors like hyperreflective foci, all important, but even when considering them, this thin double layer sign, which we think in many cases corresponds to a thickened basal laminar deposit, that itself was an independent risk factor for progression to atrophy over 2 years. And so, again, this is where I think high-res OCT has a role to play because when you're trying to look at the space between the RPE and Brooks membrane and there's not a lot of separation, having the increased axial resolution allows us to pick out different layers. And I just showed an example. The bottom example, both of them were OCTA confirmed, but you can see that with the high-res, you can actually appreciate a bright and a dark band between RPE and Brooks, which was helpful in this case of identifying this patient as being a vascularized lesion. These are just more examples of more sort of advanced sort of fibrotic cases of neovascularization comparing conventional to high-res OCT. Sometimes you can actually see, like in this zone here, to go back, where there's a communication at that edge there where the choriocapillaris kind of enters into the supra Brooks membrane space in feeding this neovascular complex. And we've started to count the number of Brooks membrane cracks now in these neovascular lesions because you can actually trace them out kind of interestingly using high-res OCT. And this is just more example of these kind of Brooks membrane interruptions that one can appreciate. So anyways, to summarize, high-res OCT certainly gives us improved visualization of the outer retinal bands, as well as interretinal features like capillaries, which can be helpful, as I pointed out. And I think it improves our ability to stage, prognosticate, and manage patients. And I think as we're in this new era of atrophic AMD therapeutics, this will be of particular value. And I want to acknowledge my fellows who worked on the projects that I talked about here. And thanks very much for your attention.
We'll have time for questions during the panel. I'm going to ask Ricky Wang to come back. He's going to talk to us about, does the outer retinal thickness present another clinical biomarker for predicting geographic atrophy growth? Thank you.
Yeah, thanks again. Yeah, and again, I want to thank my team members and also my collaborators, Dr. Phil Rosenfeld from BPI and also his team, and Caroline's Meditech. And without them, our research is not possible. So ultimate goal for our for the study is to understand how does C-RORA or a GA form and how does it grow. And this is actually a clinical question, and that's really over my pay grade. And so in this specific study, and we want to look at how OCT can be leveraged to contribute to the answers of this clinical question. And we know that GA or C-RORA starts with the drusen and then followed by degradation or degeneration of the RPE complex and also photoreceptor degeneration. And eventually makes OCT signal into the choroid becomes hypotransmission. And that we call the hyper-TD or hypotransmission OCT signals. So when this hyper-TD measures more than 250 microns in 3 dimensions, it is considered as C-RORA or GA. And in this case, so how OCT can play. Also, OCT can be used to measure these variables, and for example, the choriocapillaris flow deficit, RPE complex integrity, and photoreceptor integrity, as Justice and Vas mentioned. And clinically, so hypo-DD is required to grade the GA. And however, hypo-DD has to be measured in 3 dimensions. Therefore, to grade the GA, you have to go through B scan by B scan, which is very time-consuming. And the best way to solve that problem is to look at sub-RPE slab. So in this case, the GA can be seen at a glance, right? However, there has some caveats, and hypo-DD measurement is actually indirect measurement. It basically measures artifacts, right, in the colloid. And the noise background in the colloid is pretty high. For example, the colloidal vessels, which sometimes will give you some difficulties if you want to automate the process to quantify the hypo-TDs or GA. And so the strategy we use is to convert the OCT scans into the optical attenuation coefficient representation of the OCT scans. We call it OAC scans. And in the OAC scans, it will amplify the signal in the RPE complex and also hypopigmentation and also the calcified drusen, which really gives you the ability to automate the process to quantify. And so what the OAC looks like, and this is a side-by-side comparison of the original OCT B scans and the OAC B scan. So because the RPE complex is really highly scattering in physics, and therefore in the healthy RPE or pigments complex, the OAC value is high. And when the RPE complex is kind of compromised, the OAC value will be reduced. And when the RPE complex is gone, the OAC value is gone as well, is diminished. So all these features really helps you to do the multi-layer segmentations, particularly for the segmentation of the RPE in this case. And so this is the example of the 3D scans. And the left one over here is sub-RPE, visualization of the hypo-TDs. And this, as I mentioned, is indirect measurement, basically that measures the artifacts in the colloid. And the OAC representation really gives you the, direct measurement. And in this case, the dark spot is really kind of inverse visualization appearance of the sub-RPE. And in this case, you can look at whether this hypo-DD is I roller or C roller. And more importantly is that the OAC gives the automated approach to segment the RPE layer over here. And in this case, if you look at the OAC projection, which gives you the OAC elevation map in the right. And in that map gives you the drusen volume information and also the basal laminar deposit, which are really kind of risk factor as Vas and Justice mentioned. And so with this information, we developed an automated algorithm to quantify the GA or hypo-DDs, and based on the deep learning approach. And this algorithm really gives you automatic measurement over the time of the OAC elevation. OAC elevation, as I mentioned, includes the drusen volume and also the basal laminar deposit. And also this algorithm really gives the automated measurement of the hypo-DD over the time. And the algorithm will also give you the measurement, automatic measurement of each individual hypo-DDs, which somehow I think is important in the assessment of the growth rate of the GA. And now look at the outer retinal thickness. And we propose outer retinal thickness is defined as the anterior border of the outer retinal, outer plexiform layer to the RPE complex. And we propose this as a surrogate to measure the photoreceptor disruption. And as Justice mentioned, they developed a machine learning algorithm to quantify the photoreceptors. But we believe that the quantification of the photoreceptor can be quite difficult. And here we propose use the outer retinal thickness as a surrogate marker to measure that. And this method, of course, we believe is superior to the current photoreceptor algorithms because subretinal juvenile deposit do not interfere with the segmentation of the ellipsoid and also the photoreceptors. And algorithm can accurately measure outer retinal layer over the juven. And so this is the example of the outer retinal thickness map for the slow rate of the GA growth and median rate and faster rate of the GA growth. And bottom is the outer retinal thickness map. And as you visualize that or see that, and the correlation is actually quite good. And we put this information, plug into the other parameters, for example, the choroid capillary's flow deficit, and also the OIC elevation, which really kind of surrogate for the juven volume measurement. We put these three variables into the multiple regression model to predict at the baseline the growth rate, which provides, give you the explanation of about 62% of the GA growth. So that can be explained by the CC flow deficit, OIC elevation, which is a juven volume, and outer retinal thickness. And we publish this over here. If you are interested, you can look at. But still, you can have the prediction of the 62% using the three variables. Still, you have left 38% of the GA growth unexplained. So we are still working on that. So take-home message is that OIC algorithm provides you a novel strategy to automatically quantify the GA lesion. OIC algorithm can detect the AMD as a 3D disease and identify whether iRORA is really C-RORA. And outer retinal thickness is correlated with the GA growth. And the regression model of these three variables, outer retinal thickness, CC flow deficit, and OIC elevation can explain about 62% of the GA growth. And with that, I thank you for your attention.
So we've heard a lot about the imaging of dry AMD. Peter is going to put it all together for us and tell us why we're imaging so much and give us an update on emerging treatments for dry AMD. Peter.
Thanks. Here are my financial disclosures. All of them are probably relevant for what I'm talking about. So if we look at the pathogenesis of dry macular degeneration, the only thing that we have that's phase 3, has positive phase 3, are at the end of this graph, basically the complement system in green at the bottom there. But really, if you think about it, we don't have a smoking gun. It's really difficult to treat, to develop drugs for dry AMD because we don't have a model system that we can definitively show if in that model it works, we can bring it into humans. And because of that, we have to do so many clinical studies, and unfortunately, a lot of these studies are actually very long. So if we look at sort of the emerging treatment strategies for dry AMD, I put them into these type of buckets. I like to put things into buckets. It makes me remember things better. So the first, reducing oxidative stress. You could talk about a little bit of neuroprotection in there. Second, reducing toxic byproduct accumulation. Visual cycle modulation. This is one of the most active structures in the body, constantly converting light to energy, and that builds up byproducts. Stem cells, which cure everything, of course. Suppression of inflammation, and then we'll just call it a bucket of other approaches that are currently being looked at. So looking at this first one, oxidative stress, this is a known fact that as we grow older, our mitochondria get damaged, and this increases over time. In fact, if you look at patients with macular degeneration versus age-matched controls, the patients with macular degeneration have much more damage, more pronounced damage to their mitochondria. So one company, Stealth Biotherapeutics, has a drug that basically binds to cardiolipin and restores mitochondrial function. This is a subcutaneous injection, so not intravitreal, sub-Q. And one of the things that Justice and Sunil have really pioneered in their lab is this idea of looking at the EZ zone, as Justice has shown. And so that is being, you can use a false color image to represent these loss of EZ, which precedes RPE loss. And that's what was looked at in this study. And this just shows you what Justice's team has done, which is the dramatic increase in EZ attenuation shown on the top in the sham-treated patients versus the elamiptide-treated patients at the bottom. And it also correlates with the visual acuity outcomes with this drug. So it was a statistically significant reduction in a total EZ attenuation. This is now an FDA-approved endpoint, and so this drug is going to move into phase 3 shortly. Another drug that works to stabilize the mitochondria is a drug by Allegro called rizatigimab. Works by a similar way, but this is an intravitreal injection. Lasts roughly 3 months. In its phase 2 study, it actually showed an improvement in visual acuity. So think about that for a second. How many of your dry AMD patients at 6 months after would have a 8-letter gain in visual acuity? You can imagine that's very small. The problem is 8 letters is not enough for the FDA. The FDA requires a 15-letter gain in visual acuity. So that's a little high. And so this company is currently raising money for phase 3 to try and meet that endpoint. If you look at Alzheimer's disease, and you kind of understand some of the things that are going on in Alzheimer's disease, in particular with the beta amyloid oligomers being the main source of problems in Alzheimer's, there's so many parallels with dry macular degeneration, it's actually kind of scary. So if you look at drusen, for instance, there are collections of beta amyloid oligomers, and it can be stained as shown in the slide here. So if you want a kind of unifying theory of what may be one of the first steps, one of the first problems, is these toxic oligomers build up in the drusen. Those are pro-inflammatory, so that activates the complement system. It also, when you have a pro-inflammatory state, that causes macrophages to polarize into an angiogenic mode, and that could lead to wet macular degeneration. So maybe beta amyloid's the place we need to really be attacking, not some of these other things. Now, this is being looked at. There have been some failed studies using beta amyloid inhibitors that really just came from the Alzheimer's world, and they brought it into ophthalmology. But a couple of companies are using the idea of let's be a little bit smarter about this. And the interesting one there is Galimetics, which is using an eye drop that prevents these oligomers from forming, these monomers from forming into toxic oligomers. And being an eye drop, which would be very unique. The issue, of course, is how to get this drug approved, because if you think about it, it would reduce your drusen, but that's not an approvable endpoint. You either need vision or EZ zone or something else. So this study we're currently designing to try and figure out how to prove an eye drop may work. As I mentioned, visual cycle modulators are drugs that slow the visual cycle. So by definition, that reduces your dark adaptation and makes it difficult to drive at night. In fact, in these clinical studies, one of the things the patients have to sign is that they won't drive at night while they're in this study because we don't want them to get into accidents. There were some big studies. Fenretinide, for instance, was a big one in phase 3 that failed. But there are companies still looking at this idea of reducing the visual cycle to prevent the progression of dry AMD. Stem cells is an interesting area. Now, I'm talking to stem cells, you go into your backyard, pull something out, and pop it into an eye. I'm talking about like real clinical trials with stem cells. Well, it's true. It happens. Go to Florida. These are real clinical studies looking at the idea of using stem cells. OpRegen, for instance, is in phase 2 as we speak, but others are in it. Now, if you kind of think about it just for a moment, the RPE is polarized. So if you're just going to put stem cells in there, it could just, who knows what it'll do if just injected into the subretinal space. We don't actually know how those cells will turn into RPE and hopefully maybe even photoreceptors over time. So one of the first generation, OpRegen, et cetera, and Astellas just kind of injected stem cells into the subretinal space. But I'm going to call the second generation is putting these stem cells a little bit more matured, and they put them onto a polymer or some sort of patch that you place subretinally underneath the area of atrophy to replace the RPE. But since they're on a polymer matrix, you can polarize them in a correct direction. So this is very exciting research, of course, but it's still in its infancy. But maybe this will lead to something. The optical data is actually fascinating. If you look at other ways you can use stem cells release trophic factors. And the companies listed here are using that idea for inherited retinal degenerations to inject basically retinal progenitor cells and using the trophic factors that are released by these cells to help the dying or sick cells. But if it works in inherited retinal degenerations, there's no question it would also work in dry macular degeneration. That's where all these are going sort of in the next phase. So right now these are all in IRD, not in dry AMD. So that brings us to suppression of inflammation. This is the only area within dry AMD treatment that actually has positive phase 3 data. And if you look at the complement system, there's multiple areas within this complement system, but this system was designed to treat bacteria and viruses. You need to keep that in the back of your mind. That's the whole raison d'etre of the complement system, not GA. If you think about it, then all these pathways are designed to do one of two things. One, it produces C3A, C5A, which causes an inflammatory response, brings in macrophages, etc., releases other cytokines. Number two, it produces a membrane attack complex, which causes a pore to form in the bacteria or viruses, causing it to explode and die. And finally, you have opsonization. So C3b is deposited in all the cells in the body and all the bacteria in the body, and then your body has to come up with a way to turn that off so that the MAC doesn't form on your own cells. If you look at the genetic associations and histopathologic associations, there's no question that complement is involved in macular degeneration. We just don't know which one of these pathways is greatest. We also don't know where we need to target the complement cascade to really treat dry macular degeneration. Because of regulatory hurdles, the easiest is at advanced AMD. But if you really think about it, we should be targeting complement much earlier. You know, this should be at like intermediate, maybe even at early, to prevent progression altogether if we really wanted to target dry macular degeneration and prevent the cell death. So one of the ideas is to target C1q. Now, if you think about that, that's the classical pathway. It's activated by an antibody. Why would you do that? Well, the other things that activate C1q include C-reactive protein, as well as amyloid beta, like I just said. It has nothing to do with antibodies. So you have CRP and amyloid beta activate C1q, so it makes sense to target it because it's also found around drusen. So a company called Annexon has a Fab fragment that targets C1q, and this study was recently read out, showing no change in GA lesion area. But there's a very interesting finding, and I skipped through one slide, which is this one. So this drug is being looked at also for glaucoma because it's also neuroprotective. It prevents synapse degeneration. And if you look at the second part of the press release on the phase 2 study was this drug prevented a 15-letter loss of vision versus sham. This is an approvable endpoint now. So this, of course, is something that you could take forward because most of these complement inhibitors to date have not been able to show this, at least in phase 2. So this may be the endpoint to use as opposed to GA progression. Other companies are looking at targeting factor B. You can do this, which is the main rate-limiting step of the alternative pathway. They're using an siRNA to basically shut down factor B. Factor D We all know about lampalizumab. There's a huge failure, big phase 3 study that basically did not work. But if you really look at the data, and you look at the early data, the amount of drug that was being delivered in the lampalizumab study would not have been enough to get to the RPE and photoreceptors, the dose they were giving. And as you can recall, it didn't work in phase 2 either. So is now surprised that it didn't work in phase 3. Alexion currently has a phase 2 ongoing with a oral factor D inhibitor. So that would be kind of interesting, a pill for dry macular degeneration, and this is currently an ongoing study. The way we shut off the system is using factor H and factor I, and the levels of your factor I and factor H strongly associated with your development of macular degeneration. So companies are using the idea of using gene therapy to deliver normal factor H or factor I. And this idea then is that you have some sort of a defect in the factor H and factor I, so you can't turn off the amplification step of the alternative pathway. These studies are basically giving the correct amount back, and since it's gene therapy, theoretically for life, a one and done. And this is currently being looked at either at factor H or factor I. Which brings us to the only area that actually has a treatment, which is blocking C3. There are many companies now that we have a positive drug in pegcetacoplan and Apellis that are looking at the idea of targeting C3. And other companies are looking a little further down the cascade at C5, which also has positive phase 3, but no approved product. And so all these things are currently in phase 2 or earlier, except for Iveric. And a final area I want to talk about is CD59. CD59 prevents the formation of the membrane attacks complex. And so a company is looking at a soluble CD59 and using gene therapy to deliver it. And basically this blocks the terminal step of the complement cascade. The unique feature of this is it would allow you to keep some of the C3A and C5A effects that we talked about earlier. So we'll see if any of these work. So this is Hemaras, and a phase 2 is about to start. If you look at the immune response, everything I just talked about was on the humoral side with the complement pathway, but there's also a cellular side, which is the macrophage side. And companies are looking at this idea of that there are activated macrophages that lead to the damage that we see in macular degeneration that are not seen in age-matched controls. A company called Aviceda is using this idea to target these macrophages to repolarize them, as well as to make factor H work a little better, and this treatment is just starting with intravitreal injection. HTRA1 inhibition is also being looked at. If you looked at HTRA1 and you look at the GWAS studies, this is the only GWAS study where it specifically shows an increased risk of GA. So all the others, factor H, factor I, all the other complement factors only increase your risk of all AMD. This one's specific for GA. And the patients who have the mutation develop GA. And so the idea of inhibiting HTRA1 is being looked at by several companies. And then I'll just fly through some of these others for completeness sake, the other approaches. We know that inflammasome activation leads to damage. It's being looked at. We know that if you somehow stimulate the RPE, either with electrical current or with light, that can somehow cause the oxidative stress to be reduced. This is being looked at. And so that's the overall sort of picture. And the beauty of this is that every one of these studies is ongoing. It's in a different area. Dry AMD is a very exciting area to be in from a clinical trial standpoint, and I hope this gave you an overview of what's currently out there. Thanks.
All right, happy to take questions from our speakers before we get into the panel.
Can I ask Vas a question? High-resolution OCT is the current setup. Does it take any longer? Is it a different scan pattern? Or how's it going to compare?
No, I'm not sure if this is on, but no, it doesn't take any longer. It's the same. We use the same scan patterns in the studies that I went through. I will say one thing though is it's a bit more sensitive to media opacity because you are using a slightly shorter wavelength. And so, you have to make sure you've put artificial tears or something on the eye. You really need to have a clear cornea. Otherwise, you lose some of the benefit of trying to do imaging with that. But no, time factor-wise, no different.
Perfect. Any other questions? All right, so we're going to compress the panel a little bit time-wise so we can stay on time. These are my financial disclosures. We talked about imaging modalities for dry AMD. So I want to turn the clock back 5 years. And, to our group here, Adrian, I'll start with you. Did you see dry AMD in your practice? It's interesting hearing from other practices around the country of if they're non-interventional patients, you see them once and you send them back to the comprehensive ophthalmologist. Were you seeing them? Did you keep them in your practice? And where did most of these patients come from in terms of referrals? Was it optometry, comprehensive ophthalmology?
Yeah, indeed, I do. And 5 years ago, I did and still do see dry AMD patients. Most of them come from a combination of the optometrists and the comprehensive ophthalmologists. We usually have a system where if we check in with one or the other of us every 6 months, so essentially I'm seeing them every year, making sure their retinas, nothing's unusual or untoward or unexplained, and making sure everything's stable, and then I see them at the 6-month marker.
Okay, great. Aaron, what about you?
5 years ago, I was at the VA, and so we had to keep them in our practice. And we would see them, every 9 to 12 months or so.
Okay.
Yep.
And Vas, in terms of your imaging protocol 5 years ago, what were you doing for these patients?
Yeah, even 5 years ago, all these patients would get an OCT. We weren't doing OCT angiography. Now we do OCT angiography on some of these patients. Anybody who has a suspicious RP elevation will do OCT angiography as well. But we were certainly doing structural OCT on every one of these patients.
Yeah. And how often would you typically see them back?
So it depends. It depends. Even a few years ago, we had some idea of these biomarkers. So patients who had things like hyperreflective foci, we'd bring them back at 4-month intervals, as opposed to patients who didn't have any risk feature. They just had large drusen, then in 6 months.
So you mentioned OCTA for looking for CNV, but we also heard about the potential biomarkers of like flow deficits. Are you using that specific aspect of OCTA at this point in your dry AMD patients for risk assessment?
No, I mean, we were doing it in a research basis. I completely agree with what Ricky presented, the flow deficits and then looking at the surrounding photoreceptor alterations, I think are super useful for risk prognostication for patients, but we do this all through post-processing. If we had a simple, easy way from our devices already to spit out a risk score, then I think we would. But as of right now, no, we do that after the fact for research.
Yeah. So, Alexander, now we're in 2023, and we now have a new, option for dry AMD management. How has it changed your practice?
It's interesting if you think back to several years ago, a lot of these patients, there's publications that we weren't even coding them as GA patients. And it's been shown both in patients who have intermediate AMD with foci of GA away or even abutting the fovea, and also in now neovascular AMD patients who have GA. So I think I am looking back at a lot of my patients and looking back at their OCTs, and a lot of these patients I don't have, let's say, fundus autofluorescence, but I look back at OCTs and I can see the GA growth, and I do appreciate it much more now that we have treatments as opposed to prior years. And I think now in 2023, there is a lot of patients I wish I had autofluorescence so I could see the lesion growth. So I do get autofluorescence, but as you mentioned, Justice, it's not easy to get. We don't have it necessarily at all, the satellites. So it's not routine. The routine is still OCT.
Yeah, it's interesting. I've appreciated more some of the image review software that we have, specifically in these cases, to easily go back 5 years and be able to compare that in that way. I mean, one of the things.
Can I make just one quick
comment
comment about that, Justice? I think something Alexander said was very important, and we found that having the prior data super useful, right, in selecting patients, and then obviously having some kind of idea of their progression. If you're thinking about therapy and you want to keep them on therapy, then having that information is very useful. And so I would just put a plug in for do dense volume OCT, because if you do dense volume OCT, then you can do all of the en-face reconstructions and the like that Ricky talked about. And I think it's time to start doing that now going forward as we have more therapeutic options available.
Yeah, for me, one of the unexpected things was talking about Henry Winkler in my lab, which I wasn't expecting that at all with patients coming in. And so, Dan, what about for you? Having that historical data is great, but making a decision about, are you going to put somebody in a clinical trial or treat somebody with a therapy, are you increasing the frequency with which you're seeing people and doing imaging? Have you changed anything in that regard?
So a lot of the people I see are donors, and if they want to be seen every day, I'm going to see them. So
fair enough.
there is some truth to that. Okay, I'm going to be honest. So, but in general, yeah, I think I used to love seeing dry AMD patients in clinic because it's like a well baby check. It's like you're flying through, seeing all these complicated patients, and then you get, oh, this is great. You get it in and out pretty quick, right? Now it's a very different conversation. It's a longer conversation. It's much more involved. And people, it does, I think, it naturally leads to more frequent evaluations.
Yeah, I mean, for me, once, towards the end of last year, I started doing much more like every 3-month visits, partly because if they're not going to be willing to come in at every 3 months, there's no way they're going to be willing to come in for treatment on a regular basis. And I think that the other thing that is a luxury that we have with dry AMD is we don't have to make that decision to treat that first time we see them. It can be an ongoing conversation. Sunil, what about you? Are you getting fundus autofluorescence? Is it just OCT? What are you doing now?
So I'm getting a lot of fundus autofluorescence now. So I look at it as I'll take as many dry AMD patients in my practice to avoid the uveitis. So that's always a good thing.
I'm going to trade you
that's
for
a win.
AMI.
You get my uveitis any day of the week. But I think it's going to be really important for us to properly phenotype patients. And I think we miss a fair number of patients with retinal dystrophies. And I think fundus autofluorescence is incredibly helpful to help us determine a difference in phenotype. I think we've become OCT experts, but not necessarily in the IRD world. I think there are lots of things that can look like AMD that isn't AMD, and I think if we're going to put them down the path of either a trial or a therapy, the data we only have is really with therapy. For AMD, we need to make sure it is truly AMD.
Yeah. Peter, anything you've changed in terms of follow-up, the way you approach imaging for these patients versus what you did 2 years, 3 years ago?
I mean, definitely increased fundus autofluorescence, largely because I'm concerned about payers, right? So there are some payers that have said to their docs, we reserve the right to make sure that the drug is actually working. So being able to prove that to them, we may have to do that in the future. So the more data I have for that, the better. Now, that's not to say we can't use OCT in it, because I think that's actually going to be a lot easier. But just in case I get a fundus autofluorescence, just really rarely now, probably once a year would be the most I'd want to do it, quite frankly.
And what about, one of the questions in patients who are undergoing treatment, who are coming in, say, every month, every 2 months, who here is using pegcetacoplan at this point? So we have been we are our typical Cleveland Clinic self. It's taking forever to get it on our formulary. We're excited to now have it on our formulary. So we're just getting it into our clinics. And I think one of the questions that has come up is, as you use it, do you image every time? Do you get an OCT? Is this a straight to injection, check vision? Do you dilate? Adrian, what about you? When you're going to be using this, I'm curious what your experience has been with at Hopkins. Are you going to image? Are you going to check vision? Are you going to dilate? How do you approach?
Yeah, I feel much better, not like the Lone Ranger, because it's taking a long time to get on formulary. So that's reassuring, but also good because we can kind of learn a little bit more about things before we start using it. I do feel like there's a select group of patients that it's going to be helpful for. Starting to have those conversations. I will image with an OCT at their follow-up visits just to watch for CNV.
Yeah, I think it's the amount of enthusiasm that you see from some of these patients is incredible, and it's very exciting for them. And how you then have that discussion around it is incredibly exciting for us to have this first therapeutic available. But they just need to understand, we're not, going to have that home run effect, from a visual acuity standpoint that we saw with the anti-VEGF therapy as well. Sunil.
So I just be cautious in, injection-only visits for a new therapy. And so I want us to go back to anti-VEGF. It took us a long time to do injection-only visits. It took us years, I think, to get to that point of that we were, comfortable with it. It's a new therapy. Most of us weren't in the trial. Most of us don't know how these patients do. There are new complications that we're not necessarily so we know of, like AION and inflammation. So I just would caution people in making sure you're looking at these patients and looking at them each time, because I don't think some of these patients realize if they're having problems, and we don't know what to look for. And it's just a different, way of injecting, and different way of drawing it up and such, and that's new for everybody too, or different than what it was before. So I'd just be very cautious in saying right to injection without putting my eyes on a patient.
Yeah, and one thing I'd add in terms of like image review, I think the OCT, in addition to obviously, as you're saying, potential, what you're doing with your clinical exam, you may be wanting to look for more than just CNV, signs of, vitreous cell, signs of other things that we've learned from other therapeutics that have emerged that may be important signals, early on. With that may change that. The one other thing I would say from an injection only, even on my anti-VEGF injection only, I dilate. And I will tell you the rare times that they lose vision, I am so happy that they're dilated. With the volume difference of what this is, I personally would not do it without dilating so that you can quickly be able to look at the nerve loss.
Yeah, I was going to say, I think you both just made a really critically important point. I mean, we've also had formulary delays, so we've gotten samples, so we've been using samples, and because we had some patients who are really motivated, very interested to start, and again, we're obligated to discuss these new therapies and options with patients so they can make an informed decision. But I think that when you're dealing with a new therapy, I think an injection-only visit is a mistake. I think you've got to understand, I mean, this is a new class of agents, and I think these patients deserve to get checked carefully each time. So I'm really glad that you guys made that point.
Perfect. I think, Dan.
Yeah, and one other point I want to make is I'm seeing a surprising number of people come to me for second opinions about this drug who are being treated for neovascular AMD and have evolving atrophy associated with that. You need to keep in mind, we don't have any data. We have exactly zero data as to whether or not pegcetacoplan or any drug will be effective in the setting of a patient who has active choroidal neovascularization that's being treated with an anti-VEGF drug. It is quite possible that the mechanism of action is totally different. Maybe it's not. But the bottom line is we don't know. All of the trials to date have been at baseline are patients who had geographic atrophy and did not have existing choroidal neovascularization. It is a mistake to now recommend the use of this drug when you have exactly zero data to support its use in a patient with ongoing treatment with anti-VEGF therapy. I'm pretty stunned. I understand why people are tempted to do this, but can we please be data-driven, please? Because I'll say it again, if you use this drug or any drug that's going to follow in an eye that's already being treated with neovascular AMD, you're making it up. You got no data to defend what you're doing. Can I say it more clearly?
questions. I'm excited to introduce again Dan Martin, who's going to talk to us again about his top 5 things he's most excited to learn about in future DRCR trials. Dan.
So I gave you guys an overview of some of the sort of top trials in recent years. We're currently running 5 clinical trials now and have 4 more planned. The funding for the network is always we have to apply for a competitive renewal every 5 years. We were funded for $42 million in 27. Jenny, myself, and Adam wrote that grant. We were funded for $42 million in 2017. We just learned that we're going to be fully funded for the next 5 years. We wrote the next grant, and we asked for a lot more. It'll be up to $77 million, and the total amount hasn't been decided. But the point being that with the combination of that funding and partnering with a number of our pharmaceutical company colleagues, we're in good shape to run a lot of trials. And so we are having a blast designing a number of trials right now. We have an entire protocol development committee trying to figure out what the next geographic atrophy trial is going to be. Are we going to wind up doing some sort of comparison? Are we going to be looking at different drugs? We have some proliferative diabetic retinopathy trials that we're developing. There's a lot that's coming. But in the immediate, the things that I'm most excited to learn the results of over the next 3 to 4 years I picked out just a couple. I'm supposed to pick out 5. I didn't. So I know. Can you believe it? Shocking. So protocol AF. This is a randomized trial evaluating fenofibrate for prevention of diabetic retinopathy worsening. Anybody out there even know anything about fenofibrate? I didn't. So there's actually 2 trials that have. It's an oral medication. It's used to reduce and treat high cholesterol and triglycerides. There's 2 cardiovascular trials, the ACCORD trial and the FIELD study. FIELD was fenofibrate intervention for event lowering in diabetes studies. Both of these were cardiovascular studies. In both cases, fenofibrate failed its primary outcome, which was reduction of coronary artery events. But interestingly, in both trials, they also followed patients who were diabetics in that trial, and they showed that there was in ACCORD, I believe there was reduced by 50% the 3-step progression rate, and in FIELD it was 2-step was reduced 5-fold. So the data is pretty good, and yet we don't ever talk about this. We don't ever prescribe this medication, and those. Still, these were not the primary outcomes in these trials. So after lots and lots of conversation, we ultimately decided to do a fenofibrate trial. But part of the reason we're doing it, it's not just looking at fenofibrate. It's the opportunity to look at a number of other things that have happened in diabetes. So continuous glucose monitoring. And the world has totally changed. If you look at the ETDRS, even protocol A, some of the more recent trials we've done in diabetic retinopathy, the world has changed a lot by the continuous glucose monitoring and the GLP-1 receptor agonist, which is fundamentally changing the control of type 2 diabetes. And so no one has prospectively looked at that over time. This is an opportunity to do a larger study prospectively looking at the impact of those two newer ways of following and maintaining glucose glycemic control. In addition, we have a whole host of other retinal imaging, visual function studies that have already embedded in here. So this one trial is going to spin off, we think, 3 or 4 primary manuscripts. That's the study design, 160 milligrams a day versus placebo, 560 patients, primary outcomes, proportion of eyes with diabetic retinopathy worsening by 4 years. We're probably going to extend this study to 7 or 8 years. Depending on retention. So that's one trial. It's going to be a long time before we see results from it, but it's the kind of thing, I view this as ARADS for diabetes. That's really what it is. It's a pretty benign drug, and it's not going to have an immediate effect, but will it reduce rates long term? Protocol AL. This is anti-VEGF versus sustained release steroids for the prevention of radiation retinopathy. This is a real, okay, we started out as diabetes. Part of the reason why we were expanded was to do AMD. We began to look at a whole host of other diseases. Radiation retinopathy in many ways is similar to diabetic retinopathy. No one has studied this ever prospectively, not at the level that we're going to. And in fact, the last melanoma study that was done prospectively, large one, was COMS. That's 35 years old. We thought this was an opportunity to look at the development of radiation retinopathy, both the progressive ischemia that happens, development of macular edema, by using consecutive anti-VEGF treatment. I'm going to move through this really quickly because I'm looking at my time. This is going to be 600 eyes with a choroidal melanoma that is not underneath the geometric center of the fovea and does not touch the nerve. You wouldn't believe how many months it took for us to get there. I have the world's most amazing protocol development committee: Carol Shields, Tom Auberg Jr., Prithvi Mruthyunjaya, and then a host of other individuals who were Carol Shields. It was really an amazing group. Patients will be treated with faricimab every 3 months versus Iluvien at baseline, then a second one at 2 years versus observations. The primary outcome will be change in visual acuity from baseline to 3 years, and lots of secondaries that we will look at. It will be a nice opportunity to prospectively characterize what happens in these eyes with most exciting part to me is the wide field imaging that we're going to do on a prospective set of patients, prospectively on a set of patients over a 3-year period. Surprisingly, that actually has not been done. Protocol AM. This is a randomized trial comparing immediate versus deferred surgery for symptomatic epiretinal membranes. So we all see these these patients who come in who have an epiretinal membrane that you can have significant involvement in the center of the fovea. They're 20/25, 20/30, they're really symptomatic. Should we operate on those eyes? That's a question that we don't know. There are a lot of people who do. There are some people who believe that if you don't operate, if you leave that structural, the epiretinal membrane there, which is altering the structure of the fovea, that 3 years later when it progresses, that it may ultimately, that you may, if they drop to 20/40, 20/50, that you may do the surgery then, but you may not achieve the same visual acuity result that you might have had you intervened earlier. So this is a randomized clinical trial that was developed. Protocol AF, we are about 200 some odd patients into that trial. This trial is, I'm going to move quickly, 400 eyes. We've enrolled about 100. And that's sort of moving along nicely. It's immediate surgery within 4 weeks versus deferred surgery, and they're followed for 3 years. And the primary outcome is mean change in visual acuity. It's also an opportunity to standardize distortion. But what does every patient with epiretinal membrane tell us? When you do their vitrectomy membrane peeling, the distortion is oftentimes the most reliable thing that improves. There's no good way to measure that, and one of the things we're going to do is try to standardize that. We're going to do it with M charts, and there's a couple of other assessments of distortion that we hope to, again, prospectively characterize to see if it predicts who you should operate, who you should not. We also have a whole, we'll be collecting OCTs. We have a whole plan for how we want to use those OCTs, how we want to incorporate AI in this. To see if we can figure out who's going to progress and who doesn't, because some of these eyes who are 20/25, 20/30, they will never progress, and others do. We're going to try to see if we can develop predictors for who will progress and who does not. Protocol AK and AO is probably the study that's dominating more of our time than anything. At this meeting, Kevin Blinder is going to present the results of AK. It's going to be on Sunday morning at 8:45. AK was a feasibility study for the larger study called Protocol AO, for which Christina Wang will serve as the protocol chair, to evaluate home OCT and its role to better understand, does it have a role in the treatment of neovascular AMD? We're going to compare it against treat and extend and use treat and extend as the control. There's lots of variability in the number of injections required, and basically if you had some way to personalize that, you can think of a lot of good things that could come from that. The question is, will we actually improve outcomes and will we reduce the treatment burden? Many of you have seen these slides. I'm not going to go through them. Sorry, in the interest of time. One of the really interesting things, though, is that by doing a home OCT assessment every single day, all right, you have a patient who has neovascular AMD. You have one point in time, and you see him a month, and you inject, you see him a month later. There's a lot of stuff happening in there, and it's pretty amazing what can happen that you don't even know is happening. For example, this patient, you inject it here, and so you see the data at that point, and then they come back in here, and you go, oh, yep, you're a little better now, right? That's what you would say. What you don't know was that everything dried up for 3 weeks. You just didn't know about it. It's kind of shocking how much stuff is going on between those visits, and understanding that becomes very important. So we realized we had to do a feasibility study that was protocol AK. This was patients who were 14 patients with newly diagnosed. It's the first newly diagnosed neovascular AMD study. It's a small study. We followed those patients for 6 months. Basically, home OCT was run in the background just for us to understand. We looked at a lot of different things to plan for, ultimately for protocol AO. This is protocol AO. It is going to be a multi-center randomized clinical trial of 600 eyes from 80 sites. They'll be randomly assigned to treat and extend versus home OCT. All eyes will be treated with faricimab. And the primary, we have co-primary outcomes. It is actually a superiority trial. Superiority, because if home OCT doesn't improve something, you don't care if it's non-inferior at this point. You really want to know, is it superior? Can you produce a superior outcome in something? And there's two things that you could do that. One would be in visual acuity, and the other would be the number of injections between baseline and 104 weeks. So that's our primary objective. We're also going to learn a lot about what's happening to intraretinal fluid. This thing's pretty, I have no conflict of interest, okay? But I've spent a lot of time looking at this thing, and it's, what I've learned already, I can't wait to see what else I'm going to learn, because there is much to know about what's happening with the fluid dynamics between treatments. And there's lots of stuff to look at. Does the duration of the first fluid-free interval predict the duration of the subsequent intervals? I think I already know the answer to that from CAT. No. So does the speed of fluid resolution predict durability or outcome? People assume that's true. If you think of the whole treat and extend algorithm, it's kind of flawed, really. We're trying to find that right interval, but the fundamental assumption is we think that interval is going to remain stable over time. Why would it? Vessels mature. They change how they leak. And some people do, but I can tell you a lot of people don't. It's another CAT paper that's coming. So does the speed of fluid resolution predict the durability? So if you see something go really so fast, does that predict how durable it's going to be? I don't know the answer to that one, and I'm anxious to see. How often does fluid reappear and then disappear? So one of the real surprises to me is that, surprise, surprise, there's lots of little blips of fluid that occur, and they're real. You can see them on the OCT. You can see them measured in the plots, and yet you look 2 days later, they're gone. The RPE actually works. You know, the RPE actually pumps some of this stuff, some of this dry. There's a ton of stuff to be learned here. And we're also it's an opportunity. 5 years ago, when non-exudative CNV became a thing, we all recognized that this was an entity. We actually designed a whole study in the network to prospectively look at it. And then Phil was doing a very nice one already, and a few others. MacuStar was doing some stuff. And so we decided, you know what, we're going to wait until we have the vehicle to embed this ancillary study into it. On the basis of CAT, Harbor, Ivan, most of the other newly diagnosed neovascular AMD studies, about 50 to 75% of patients at baseline who have unilateral disease. That gives you an opportunity to follow the fellow eye with OCT, OCTA, And so there's a whole host of things we have planned to look at the movement from nothing to non-exudative CNV, from non-exudative CNV to exudative CNV. Some of that's known, but it will not be known at the level we're going to do it. So in summary, Home OCT is a promising new imaging platform that has the potential to personalize anti-VEGF treatment for neovascular AMD. It will expand our understanding for retinal fluid dynamics. Go see Kevin's presentation for protocol AK. There's some interesting stuff in there, and we have finished the protocol. The startup and certification has already begun, and we expect our first patient enrolled in September.
Thanks, Dan. And I'm happy to introduce Aaron Lee again, who's going to talk with us about towards continuous disease severity grades using machine learning. Aaron.
Thanks, everyone. It's always tough to follow a talk from Dan Martin, but I'll do my best here. So this is really going to be centered around MACTEL type 2. These are my financial disclosures. So why do we need continuous disease grades? I've been asked this a couple times when presenting this work. So traditionally, disease grades have been fairly coarse, in my opinion. We take a disease that can span the spectrum of somebody's life and try to boil it down to 3 to 5 steps. But really, human diseases don't exist on discrete steps. They follow some sort of continuum. And then on top of that, some of the clinical trials have tried to show a 1 or 2 step difference in grades, and they can end up being underpowered. And so, in the realm of MACTEL type 2, hopefully everyone in this audience knows this classification from Gas Bloody from many, many years ago. You may not be as aware of a new classification system that was led by Emily Chu as part of the MACTEL consortium, where they used cart tree analysis to try and classify MACTEL into 7 different grades or stages. And so as our group is part of the MACTEL consortium, and because we do a lot of deep learning and AI work, we wanted to see if there was some way we could automate this, because I don't think most clinicians want to sit in their offices and try to figure out which one of the 7 grades a MACTEL type 2 patient belongs in. And so we use the MACTEL database. So there's about 1,100 patients who have had multimodal imaging, and they've had, most of the patients have had reading center level grades by features. And in terms of the deep learning approach, what we did is we took the central 20 slices out from a 97-line raster. We used a neural network known as an efficient net, and we took a multi-view approach. And this technique came from the computer vision literature. Basically, they wanted to be able to take multiple views of a three-dimensional object and be able to tell exactly what that was. So we basically took the OCT slices as different views of the same object. When we did this for trying to classify into the 7 stages, we reached an accuracy of about 63%. More importantly, the confusion matrix is sort of all along the diagonal, which is a good performance. And what's nice about this is it's a fully automated system then that can take somebody who has a MACTEL type 2 and give you one of those 7 grades. But what about a continuous scale? And so in the field of machine learning, there's something known as dimension reduction. And the overall idea is that if you can somehow take something that can be described with many, many different dimensions, you eventually want to be able to boil it down so that ideally 2 different patients that are very similar to each other are very close in this 2-dimensional space, and 2 patients that are very different are very far away. And if you can successfully do that, then you've achieved this dimension reduction. And so this is a little bit getting into the technical weeds of deep learning networks. And you may have read a lot of papers of AI models doing X, Y, and Z. But a lot of people don't realize that a lot of people build these models to come out here to do what they're interested in. But right in the middle, inside of here, there's something very valuable that's happening. The model's actually learning to pull out features on its own that are very, very important to do this task that you're trying to force it to do. And so what we did in our approach is we then took the feature vectors coming out of the multi-view approach and then did a dimension reduction technique in machine learning known as UMAP. And by doing that, we could project OCT volumes into points in two-dimensional space. And so here, each little point here is a different OCT volume of a patient's eye with MACTEL type 2. And what's really neat to see is that people up here have basically no features of MACTEL type 2, and the people down here have the worst form. And they're assembling along basically one manifold or one continuous line. And so that allows us to essentially pull out, a stage like 1.3 out of somebody along this continuum. This next video here is sort of a visual demonstration or technical demonstration where we took that continuum and made a web tool that people could sort of interact with that shows the multimodal imaging that was present in the data set and where they sort of fall along this continuum. And so at the top row, you sort of see the OCT-B scans, and then in the bottom rows, you have the infrared reflectance, the autofluorescence, and the blue light reflectance. And as we sort of move our mouse down along this continuum, you can see more and more severe phenotypes of MACTEL type 2 appearing. And what's nice about this is that basically it allows people to sort of interact with this tool to understand where disease sort of falls along and progresses in MACTEL type 2. So in the interest of time, I won't play the entire video. So some people might say, well, that's great, but how do you know that's actually useful or real? And so we did a validation study where we took people from the reading center who had been grading MACTEL type 2 images for many decades. And we took two pairs in the upper right where it says 1 grade difference, two pairs that were 1 grade apart. And we asked humans to tell which one was worse, essentially. And if it turns out that that clinicians are very, very good, or reading center folks are very good at telling which one's worse, which one's better when you present two images. And so you can see that the kappa values for the human beings, which are the G2, G3, G4, G5, are very, very high. But what was encouraging is that last bar, which is the UMAP, which is our dimension reduction technique, also had a very high kappa compared to humans. Now, what was much more challenging is when you took pairs that were in the same grade, so in the lower left there. These are two images or sets of images of two different people that, according to Emily's grading system, would exist in the same grade. Human beings could sort of tell with a reasonable kappa that they were one was worse than the other. So it does indicate that there's finer steps of grades within, even in a 7-step scale. The lower right is sort of, in my opinion, the most important validation that we did. We took the same eye over time, and since MACTEL type 2 is sort of a continuously worsening disease, you would expect that the later time point has worse disease than the previous time point. So we have sort of an objective ground truth there. And what we found was that the UMAP grade was actually more accurate than human beings trying to tell which one was worse. So in conclusion, we showed that a deep learning approach could classify with Emily's new grading system, and that with the continuous scale, we might be able to extract them from deep learning models. And more importantly, I think this overall approach could be applied in other disease areas like AMD and in diabetes, and lead us to a place where we can think about human diseases on a more continuous spectrum. So again, I want to end by thanking all the lab members and funding sources. Thank you.
Thanks, Aaron. And now Vas is going to talk with us about ethnic differences in diabetic retinopathy lesion distribution. Vas.
Thanks, Justice. These are my disclosures again.
And so, okay, so first of all, I want to make the case for why this talk is relevant and why are we interested in the distribution of lesions associated with diabetic retinopathy. And some of you are aware that, that there is kind of some upheaval in this area. And our standards for assessing the severity of retinopathy and predicting the risk for progression, they're in a state of evolution. There's this moonshot program that's asking the question, do we need to rethink our staging of diabetic retinopathy? Aaron alluded to it a bit in his presentation. And we, of course, all know the historical gold standard, which is, of course, the ETDRS 7 standard fields, where we assess our particular patient, comparing them against various standard photographs, and we count the number of fields affected by a certain severity of different diabetic lesions. So some of the limitations of this current system, which is based on these 7 standard fields, the concept was, well, that's a pretty representative sample of the retina. But the problem, though, is that you're leaving about 70% of the retinal surface area that isn't being considered. And so the question really is, are we sure that such a limited sample of the retina is enough? And obviously there were some concerns raised by some nice work that was done by the Jocelyn group, where they demonstrated that if you actually considered the peripheral lesions, I mean, we're talking about lesions outside the 7 standard fields, that would actually alter the diabetic retinopathy score in many patients. And in fact, they did a pilot study where they demonstrated that eyes that had, and I'll define this in more detail, this predominantly peripheral lesion concept, those eyes had a substantially higher risk for progression to proliferative disease compared to patients who didn't have predominantly peripheral lesions. And that, of course, led to Protocol AA, which I guess didn't make the cutting room floor from Dr. Martin. Must have been number 6, must have been just past number 5. But AA actually, as many of you know, evaluated this question, and they demonstrated that predominantly peripheral lesions, or PPLs, on fluorescein angiography were associated with a higher risk for progression. Interestingly, the top-line result for color photographs didn't show that relationship, and I have some ideas about why is there this correlation that we can get into. But interestingly, in particular, I think the mild and moderate patients behave somewhat bizarrely on the color photographs. But in any event, you could see that if you looked at the patients with moderately severe or severe NPDR, you did see a higher risk in patients with predominantly peripheral lesions. In any event, I think there are a lot of questions, though, about that you need to really dig into in understanding this data. But how do we determine that PPL, or predominantly peripheral lesions, are present? And so you might be interested to know in the Protocol AA, what the research group did was they said, well, we can look at each of these 5 peripheral or these 5 ETDRS fields that are sort of at the edge, ignoring field 1 and 2, and then look at their corresponding peripheral field. And basically they said if there are more extensive lesions, more lesions in any of the peripheral fields compared to its corresponding ETDRS field, that eye is predominantly peripheral. Okay, so it didn't matter if the other fields didn't show that. As long as a single one of those pairs between the peripheral field and the ETDRS field showed more lesions in the peripheral field, that case was determined to be PPL. But you might imagine, actually, let me go back for a second. You might imagine, well, you could do this other ways, right? Why not consider the entire periphery outside of the 7 standard fields relative to the area inside the 7 standard fields? And we had published that depending on the methodology that you use, your percentage of PPLs could dramatically differ. So this is a paper that was published in the JAMA Ophthalmology, where you can see these are the percentage of patients who'd be classified as PPL versus PCL, I'll call it predominantly central, based on a global versus a single field method. And I think you can see that the results are quite dramatically different. In fact, there's many different ways you can slice this, as I'll get into. I do think I agree completely with Aaron that this is not really where we want to be. The future is really going to be about automatically quantifying these lesions and looking at the severity in a continuous fashion. This was a paper where we tried to do that we did in collaboration with the Jocelyn group. We quantified all of these different lesions. I'm sorry, it's a busy table, so I'll just highlight. Basically, the bottom line is we found that the number of lesions, in particular hemorrhages and microaneurysms, certainly predicted the risk for progression, but also their distance from the foveal center was an independent risk factor for progression. So you might think in the future, we might simply represent all lesions as a function of the type of the lesion, the number of lesions, and their distance to the foveal center. But anyway, we're not quite there yet. That's sort of where we're moving to in the future. But really, what I wanted to sort of, I guess the real focus of this presentation is, well, I think we have some data to suggest that peripheral lesions, considering the entire fundus, might be important. But the question is this relevant to all ethnic groups, and are there differences in the distribution of these diabetic retinopathy lesions? You might say, well, why are you even thinking this is a question? Why should I even be concerned about ethnic differences? And certainly we have a lot of data suggesting that diabetic retinopathy may have a different phenotype in different ethnicities. Very nice study from Singapore in the SEED study. They did demonstrate, for example, a higher prevalence of diabetic retinopathy in Indian Singaporeans compared to ethnic Chinese and ethnic Malays, even after adjusting for various other risk factors. In addition, my colleague Dr. Saraf, who couldn't make it here, many years ago had demonstrated that there can be a different phenotype of diabetic retinopathy in Latino patients compared to Black patients. Of course, they didn't look at this question of peripheral versus central distribution in that study. But that actually inspired us to study this question. We looked at a large series of patients collected through an Indian version of the diabetic retinopathy research network, looking at classifying patients into PPL or PCL. And interestingly, they found a higher proportion of patients who had predominantly central lesions. And I will say both in the pilot work from Jocelyn as well as in Protocol AA, the breakdown was about 50-50 using that method. And so this was quite a substantial difference. And we wondered, well, maybe this is just a spurious result. Let's study this more carefully. So we wondered about other ethnicities, and this is the recent paper on this topic. This was still a relatively small study, retrospective, of patients, including South Asian, East Asian, and then both non-Latino Caucasian and Latino patients that we collected in our clinics. And so again, we used a pretty exhaustive method. We actually segmented every single lesion because we wanted to be very confident about the assessment strategy here. And we actually weren't sure how to grade PPL. I shouldn't say, we weren't sure what the best method was to determine PPL. So when you don't know how to do it, you do it every different way, right? So we looked at we considered the number of lesions, we considered the size of the lesions, because maybe it's not just the number, but the surface area occupied by the lesions. And then we looked at this any field or the single field method, which the network used, versus this sort of global strategy. Okay, so we graded them, and this is just a lot of words to say what I just said, which was looking at it these many different ways, basically. And so what did we find? And so this is sort of a description of this cohort, and I'm going to focus on the treatment-naive eyes here. As you can see in a moment, you can see most of our patients had moderate NPDR, so I'll show you specifically the moderate NPDR cohort. But this is sort of the top-line result from that study. And again, each of the bars in the various blocks represent a different method, but you can see that the percentage changes quite a bit depending on the method you use, single field versus global, area versus frequency. But the bottom line is the trend is always the same. And we did find this very interesting difference. You can see the striking difference between East Asians and South Asians in this particular study with, and again, you can plot it in different ways, but the bottom line is the proportion of predominantly peripheral lesions was highest in East Asian eyes regardless of the method that was used. And again, we could look at it specifically in patients who were treatment naive and had moderate NPDR, and the same relationship held. So to summarize, the topographic distribution of diabetic retinopathy lesions appears to vary among different ethnicities, and that's regardless of the strategy used to determine the presence of predominantly peripheral lesion. I mean, I have my own ideas on how that should be done. But in any event, East Asian eyes in particular were more likely to manifest predominantly peripheral disease, whereas South Asian eyes were more likely to manifest predominantly central disease. Now, what is the clinical implication of this? The answer is I have no idea because we haven't studied that question yet. But we obviously need larger prospective longitudinal studies to confirm our findings, but then to elucidate the prognostic implications. So I want to in particular acknowledge Ye He, my fellow who really did all the heavy lifting on this project, and our other fellows and collaborators. Thanks very much.
Our next speaker will be Sunil Srivastava, who's going to talk to us about quantitative assessment of inflammation in uveitis.
Thanks for sticking around. Here are my financial disclosures. I used to cite this paper. It was my favorite one. Basically summarized, we were terrible at taking care of uveitis patients, but I don't need to tell you that because just pay attention to what's been going on in the past few years. We've missed a lot of inflammation, whether it's with drugs, whether it's immune therapy for cancer, whether it's gene therapy. With each new trial or therapy or systemic therapy, there's a real risk of intraocular inflammation. We are biased because we see it in ophthalmology, but I'll tell you the number one place this happens is actually cancer therapy. There are a number of cancer medications that never make it to prime time because of the intraocular inflammation they cause. Back in the HIV days, Dan will recall multiple HIV medications that didn't make it because they caused retinal toxicity. So these things can be missed within a trial very easily because the number of patients, sometimes it's the investigators, sometimes it's the imaging. Imaging impacts our inflammatory disease management. There's a potential to do lots of good things with imaging. You can recognize the disease earlier, you can diagnose challenging diseases, and really, let's be honest, if you're not really good, it gives you an opportunity to not miss it. And I think this is something that he highlights because I think we have to remember how you learned to quantify inflammation when you were a resident. Take a slip beam, turn it on high, count the cells. But they're moving. Okay, mentally correct. How long should I stare? About 1 to 2 seconds. I see somewhere between 3 and 12 cells, so I'd say it's traced to 1+. Your senior looks in, there's 700 cells. This person has 4+ cell. And that's where we learn. This is this thing that's passed on from each person, and we don't think about the machine that we're using, the light setting, or the grading system that we use. Our grading systems suck. Aaron's put it up really, really well. They're all ordinal. They were originally made for a descriptive tool, but they've turned into a quantitative tool for us to assess every patient. The area of agreement in the CAPA scores is moderate at best. If you ask 2 uveitis specialists to see the same patient and you hope to get the same grade, good luck, because it's probably not going to happen. And what is active disease? We have this mentality, it's 2+ cell or 2+ haze, but if you ask most people, I'm treating patients before they get to 2+ cells. I'm treating them when they have cystoid macular edema. I'm treating them when they get vascular leakage. And I'm treating each disease differently because the consequences of inflammation are different for all these diseases. And so for many of us, imaging has become the biomarker to treat, whether it's CME, a leaky FA, choroidal lesions, those with hyperautofluorescence to get to hypoautofluorescence. And if we're going to use imaging as a true biomarker, we need to come up with better quantitative tools, which are continuous. So if you imagine if we just use OCT as an example, in 2 of these examples, the OCT thickness metrics that we're used to would not be adequate to tell you whether or not a patient was getting better. And you could use other tools, maybe segmentation analysis, to identify it. But in a number of these, this would have a normal contour. And that would be troubling because you would probably miss the AMPI patient, the syphilis patient. So our goals have been pretty clear for a long time. We want to use imaging devices that we already have in our office. I'd love to buy as many OCTs as Voss has. I don't have the time nor the money. Dan won't get me all of these. So we got to use what we have in our office. We need to develop our own software, produce reliable and reproducible measures, develop a new nomenclature, and use imaging as a surrogate biomarker for the severity of intraocular inflammation. We've done this with a number of things, starting from the anterior segment, developing anterior segment OCT. But we've shown this before, but I'd like to show what we've done with this. So with anterior segment OCT, all of a sudden you have a power and the ability to look at a patient and look at these OCTs and look and actually identify potentially the difference between infectious and non-infectious, something that's very useful for us as clinicians. And these imaging metrics, these very specific findings, can actually be used to determine the difference between those 2 types of inflammation. We've used it in cataract surgery patients, post-operatively. So you think of the number 1 cause of inflammation, besides lots of medications, is actually surgery. And how do we quantitate inflammation with surgery? Well, we decided to look this in cataract surgery because it's the number 1 surgery. In the first couple of patients, we said, hey, we'll let the cataract surgeon grade the majority of these patients. Unfortunately, all the patients were quiet, according to the cataract surgeon, because no one develops postoperative inflammation. And then we decided, hey, why don't we get the uveitis specialist to do it? And what we found was there's really no correlation to the cataract surgeon grading with our automated system, but there was even the correlation with our uveitis specialist wasn't perfect because we're talking continuous metrics versus a grading system. But what was really interesting is once you had that data, there was correlations between a large amount of cells that are seen at post-op week 1 and developing postoperative cystoid macular edema at any point in time. And then when you started looking at things like iris color, There's a difference in the number of cells, very small, very subtle, between brown-eyed patients and blue-eyed patients, which may explain a lot of the clinical findings that we currently see. What we decided to do is play with this a little bit more. What if we took our OCT, put it in a clinic? Could we remotely diagnose patients with red eyes? We get these calls all the time. I have a patient with a red eye. I don't know what I'm seeing. Why don't we put them through an OCT in the optometrist's office, get those images to come to us remotely? Can we remotely grade them and determine who needs to be assessed immediately and who we can wait on? And it turns out if we just have a novice student look at this, you're about 75% right. But if you use the automated system and someone who's trained, you're almost 95% right in determining the diagnosis, and you'll never miss a patient who has uveitis. Now we have a robust tool. We can use it, but it's only one aspect of the inflammation because it's not just the front part of the eye that we have to deal with. We have to deal with the back part of the eye. And there are lots of different ways of assessing inflammation in the back. We've shown previously that leakage and activity essentially go hand in hand. If you leak, you're probably active. And Justice and I, many, many years ago, started working on a system to develop an automated leakage tool that we could use for lots of different diseases. I picked uveitis, he picked diabetes, I think he won. But what we understood was that leakage was an important determinant of outcomes in multiple retinal vascular diseases. And looking at our own data set, we found it's actually the most powerful predictor of lots of posterior segment tools, OCT, vitreous haze assessment, OCT assessment of vitreous haze. Retinal vascular leakage still was the most predictive of activity. And what this allows then is some more powerful stuff. What if we could actually assess how drugs do in very unique scenarios? So this is the impact of retinal vascular leakage using ultra-wide field fluorescein in pediatric patients on adalimumab. We're asking a very simple question. How do you know when you should switch patients who are on this therapy? How can you tell when it's not working? Well, it turns out if you don't have any improvement on leakage metrics by month 3, the likelihood is that they're never going to have any improvement of their leakage by year 1. And you can see and understand that maybe we should make the switching based on these leakage metrics sooner than we currently do in our practice. Justice showed really nicely the use of automated ellipsoid zone analysis and looking at the outer retina. And I became really interested in looking at this because multiple inflammatory diseases obviously present in the outer retina. Whether it's a disease like AMPI, you can actually use this tool to actually quantitate how well the patient recovers or how poorly the patient recovers. And this is really important in a disease that, believe it or not, has a really strong implication for many of our outer retinal diseases. Think about dry AMD. Think about inherited retinal diseases. The EZ will never get better. The only disease where the EZ gets better is uveitis. And the best predictor or the best model of that is syphilis. Syphilis is actually a great model for outer retinal disease and to actually identify those who could actually have potential to improve. So our ability to quantitate and see patients with outer retinal disease improve actually gives us a window in learning things about other diseases like AMD. Intraretinal fluid analysis, obviously important when you look at things like cystoid macular edema, but now that you have these metrics, we actually have a continuous metric to follow patients. So in the last few minutes, I'm just going to show you that we did a study where we actually combined all three. I'm not going to give you all the nitty-gritty details, but I'm going to come to the big conclusion where we compared a clinician, myself and Dr. Sharma, just looking at our clinical assessment of a patient and comparing that to an independent reader who just looked at images and a gold standard of looking at the patient and the imaging to determine activity. And it turned out clinicians, at best, have a 50% sensitivity at identifying activity. But believe it or not, the masked reader, without even looking at the patient, looking at these assessments, has essentially a sensitivity of about 98, almost 100% in determining activity. So why is that important? Well, now you can actually think about it. You can actually use quantitative tools to determine activity. And it doesn't matter what disease it is, but you could imagine a patient who's on a new therapy, who has uveitis, or who walked in with postoperative changes, who gets 3 quantitative measures, AC cell, central subfield thickness, and retinal vascular leakage. And you could look at those numbers very quickly and say, I think this patient's active, based on the anterior segment and based on the leakage. I'm going to start this patient on some sort of therapy. I see improvement of that patient very quickly in the anterior segment. You know what? The retinal vascular leakage doesn't get better. I don't know what that means. I'm going to taper this patient off and see what happens. Well, it turns out that was the wrong decision because that retinal vascular leakage actually identified that patient to still have some activity. They come back and ramp up. So it gives us a new way of it, or at least a different way in assessing these patients continuously. And once you have these assessments, it allows you to do some pretty powerful screening tests. So in summary, imaging is an important adjuvant in managing these patients. Continuous measures are available, and they can be generated from common imaging modalities. This is going to improve our care. It's going to make us better clinicians to identify something most of us are not able or not comfortable to do, and it's going to require additional work to correlate these metrics with things like intraocular sampling and functional outcomes. It's a lot of work from a lot of people. A lot of those people are here on the stage. Thank you very much.
Thanks, Sunil. And our next talk is by Adrian Scott, who's going to be talking about sickle cell maculopathy. Is the retina a window to the brain? Adrian.
Thanks, Justice. Thanks for your attention, everybody. So just talking a little bit about some observations that we've made in children that we followed with sickle cell. Financial disclosures, none relevant. So the increasing body of literature is showing us there's some connection. We've heard a little bit in this evening's talk. There's some connection about what's going on with the eye and what we see in the retina, specifically the macula and the microvasculature. There's a growing body of literature that describes imaging findings in patients with a variety of neurologic diseases, Parkinson's disease. We see this image here from a patient with Parkinson's, frontotemporal dementia, Huntington's, ALS, and Alzheimer's. Here's an example of a study published in the Journal of Neuropsychiatry, Neurology and Neuropsychiatry, that shows retinal imaging in Alzheimer's disease. This is a scan of a patient with Alzheimer's disease in which choroidal thinning was noted to be taking place. So this is a very common type of OCT scan we see in our clinic in patients who have sickle cell disease, and it's a very characteristic. Sorry, can you go back one slide, please? It's a characteristic retinal thinning that we often see can involve the central retina, but can typically involve that field 3, that temporal retina, and that's a known watershed zone in the retinal circulation. This is a study we did with our, she was a fellow at the time, Dr. Sally Ong. She's on faculty now at Wake Forest. And we imaged in a cross-sectional fashion children with sickle cell disease. And this is, I call this a tale of 3 10-year-olds here. So there's 3 different scans here, and the first is an unaffected control patient without sickle cell disease. The second is a patient with hemoglobin SS, homozygous genotype. And you'll note the significant amount of thinning that involves the central retina, and then also corresponding flow deficits in OCT angiography. And this is a known observation that patients with sickle cell disease often do have flow deficits. I'm sorry, can you go back one slide, please? Flow deficits in their deep, more so than superficial capillary plexuses on OCTA. And then the variant patient or hemoglobin SC patients or thalassemia patient, this patient also has the flow deficits prominently in the deep capillary plexus. In that watershed zone, it's very common. And this study taught us that the vascular abnormalities often precede structural abnormalities or thinning on OCT. So you see the flow drop, capillary flow drop out before you can even see thinning. So we started to think about silent cerebral infarct. This is very common in sickle cell disease, and 90% of children with sickle cell anemia have these silent cerebral infarcts in their MRI, localizing to the internal border zone of the cerebral circulation where the flow is at its nadir. Here's an example of some areas of some scans with silent cerebral infarcts. So that begs the question, are silent cerebral infarcts on brain MRI associated with vascular phloboids on OCT angiography in pediatric sickle cell disease? So we looked at our cohort, approximately 60 patients, and the retrospective review. This is a post hoc analysis of the cross-sectional study that I showed you of pediatric sickle cell. And we included children who had OCT angiography and MRI. We did publish this in the Journal of Retina in 2022. So 68 eyes, 34 patients were reviewed, 28 eyes, 14 patients were included who had OCTA and MRI. 8 patients had silent cerebral infarcts on their MRI, diagnosed with a special scan from our neuroradiologist at Johns Hopkins, who follows these cohorts of patients as well. 7 of these children had hemoglobin S disease, and 1 had hemoglobin SC. There was an even male-female split, and we didn't see any significance in systemic associations, such as patients that were getting different sorts of systemic therapies, transfusions, hydroxyurea. Here are our findings with the superficial capillary vessel density versus deep and versus the SC-OCT thick thinning. And so we found that the temporal paraphobia was indeed significant for patients both having silent cerebral infarcts and also the percentage of loss of flow on deep capillary plexus flow. And then also they had corresponding intraretinal thinning on their spectral domain OCT. Here's an example of some patients from our study. You can have a 17-year-old child with hemoglobin SS. The arrows are pointing to silent cerebral infarcts. I'm sorry, can you go back one slide? I think skipping ahead. And I often follow these children with multimodal imaging. I like to look and see so you see the superficial capillary plexus, the deep capillary plexus with the loss of flow, the characteristic intraretinal thinning there, and you can see the thinning and the ETDRS thinning map, and then also corresponding flow deficits or corresponding silent cerebral infarcts on the MRI. The wide field angiogram also does show some subtle peripheral non-perfusion. So are these things related? We do believe there is some correlation. Here's another example. This is a 10-year-old homozygous child who has silent cerebral infarct on her MRI. Again, corresponding, this is her thinning on ETDRS thickness map, and then you can see the B scan with the retinal thinning. So we think there's some correlation between the silent cerebral infarcts and these areas of loss of vascular flow. This is a small study. It's a post hoc analysis, retrospective design. Also, MRI is standard of care for children with pediatric sickle cell disease, but often compliance with this is variable. It's a tough procedure to get. It's an expensive procedure to get, and we don't often get it. As we're supposed to per their standard of care. But we do feel like there's a signal here. It's more common in hemoglobin SS disease when patients have these flow deficits on OCTA. And then a question is, can we use OCTA as some sort of a surrogate for getting the cerebral MRI yearly? Is this some sort of biomarker we can tell who's at risk for these silent cerebral infarcts? So at this point, we've imaged over 100 children prospectively, and we're imaging them over time, so we can try to catch them and see when the actual vascular flow deficits are happening and when that corresponding OCT thick thinning actually occurs.
Well, I think we want to end actually sort of on time. Why don't we just first start with some questions for the panel? I was going to actually ask Adrian, so is there a management change in patients who have silent cerebral infarcts from a sickle cell perspective? So if you did, let's say the OCTA was the correlate, would it change the management for hematology?
Yeah, it's really interesting because it's underdiagnosed. We call it silent cerebral infarcts, but they're not really, that just really means that you can see it on radiologic imaging, but neurologically they seem intact. However, these kids have increased ADHD, decreased school performance, decreased career performance. So I think that knowing these infarcts exist definitely will help maybe focus or kind of somehow plan or enrich their learning program over time. I think they're kind of underdiagnosed as kind of underachieving kids, and they really have something, organically going on with them that can explain some of these issues with learning.
Boss, were you going to say something? No, I was going to say, in Susac syndrome, something I see a fair amount of, this correlation is seen, that when they have the artery occlusion, the MRI changes don't come for later on, but they clearly have like infarcts that develop much later. And so the fluorescein and the OCTA change first before the brain changes. So it's interesting. I was curious whether or not if you were sensitive enough to pick up something, whether you could actually do something to prevent an infarct.
Yeah, Jenny Lim actually has one of the best studies that I've seen in looking at sickle cell and maculopathy, and it just was a proof of concept that hydroxyurea is really helpful for slowing rates of retinal thinning in sickle cell disease. So again, compliance with hydroxyurea is low at times, so that can again be an extra incentive to encourage patients to take it and take it early.
Excellent. Well, questions for the panel? Otherwise, we'll I think we can just do, we got to do the drawing as well. Maybe we'll do one case. Is that fine? Or what do you want to do, Peter? You want to go sleep?
What does everyone do?
All right, we'll do one case. Let's assume you can see we're going to do one case, and you can see and examine the retina. Now, for this panel, that's asking a lot, and you get an OCT in everyone. I'm going to ask, do you need anything more? So here's we're going to just do it by disease state. We're going to do only one disease, CRAO. So you get a call from one of your colleagues, painless vision loss for 12 hours. They see a cherry red spot, and they've diagnosed the CRAO. I can send you the OCT. Here's the OCT. Do you want anything else? Do you need anything else? Should this patient go right to the emergency room? So I start with Aaron, hometown. You're on this time zone, so you should be awake.
Okay.
We're gonna go with the people on the West Coast time zone. What would you do? At the VA, you were trying to get home at 5:15, and you get this call from one of the satellite offices. What are we doing?
Going to the ER.
Going to the ER. Do you need anything else? If this was like at 9 o'clock in the morning, and is there anything else that you need? Does it change anything for you?
I think the sooner they can get to the ER, the better.
Yeah.
Yep.
Excellent. Adrian, how about you? Anything that you do different for like a CRAO? Is there anything you use to nuance this? Is this someone who just goes in, or do we need to do any other imaging?
I agree with Aaron.
Okay, excellent. We all agree with Aaron. Anyone do anything different? Vas? You don't see any patients anymore, or some days, but you're OCTing everybody. I don't know what's going on there. Looking at the peripheral lesions on Indian people. I got it.
Yeah, that was pretty funny, actually. But
Thanks.
no,
I like the validation.
you need to get them to the ER as quickly as you can. But still, while they're on their way out, I might want to, get a bit more history and kind of
sure.
know.
No,
you want to know, obviously, if it's embolic,
course.
arteritic, that kind of thing that might be able to give some additional information to the ER accepting physician.
We're going to nuance this in a second because everything's a trick when I do a panel. So I'm going to give you the rest of the history. This was a 25-year-old female who presented with a sudden painless vision loss in her right eye. She was seen by a provider. She had LP vision and a diagnosis with CRAO. She was sent to the ER for an admission, had an extensive workup, CT angiogram. She's seen HEONC. She saw rheumatology. Everything was negative. She was starting on anticoagulation. And so she presents for follow-up, her first ophthalmology follow-up, 2 months after the ER visit. So she's LP 20/20. She has a quiet eye. Here's that right eye and the left eye. Justice, anything interesting to you when you look at this? The retinal thinning, anything else that you see? Anything that worries you?
I mean, when we look at the right eye there, as you said, you see extensive interretinal atrophy, a little bit of that hyperreflectivity that's is still actually present. I've always struck at how long that can hang around for. Looking at the left eye, I mean, the one thing that is interesting is that you see some ONL thinning temporally, and in a 25-year-old, that's a little bit unusual. Whether or not that's clinically relevant or not, it's hard to say. She has no symptoms in the other eye.
No symptoms, and the fact that you look at the ONL on any OCT is amazing to me. So, Vasa, does this OCT, I'm sorry, I already asked you a question. I'm going to ask Alexandra. Does this OCT or this presentation make you wish we did something different initially? Should we have done something different from an imaging perspective, or everything good, we go to the ER, that's the right move?
Well, I agree that these patients definitely need to be seen in the ER, but I do like to get some imaging if I can, especially if I'm seeing patients myself. I do, this doesn't apply necessarily to this patient, but for elderly patients, I like to see their choroidal perfusion with FA,
sure.
and to see if they have large areas of non-perfusion. This is 25-year-old, so it's different, but you always wonder why 25-year-old has this, and if the other eye is at risk.
So here's the fluorescein. The fluorescein looks relatively normal. If you look at this, the perfusion, maybe you can hallucinate that there is some change in perfusion centrally, but overall the perfusion actually happens squids. It's 24 seconds on your fluorescein, and then 5 minutes and 18. Other eye looks fine. So is this a vasculitis or an occlusive event? I work up the patient again because that's what all I do, besides seeing dry AMD patients, and I think it's vasculitis, but I don't have any evidence of it. I started this patient on anticoagulation. I'm suspicious and nervous, and I say to the patient, call me anytime. So this patient returns 2 months later, now seeing stars and floaters in their left eye, sees my awesome fellow. I just left town for 1 day because I only got 1 day of vacation approved by Dan. So hand motion in the right eye, 20/25 in the left eye. Now with cell, and now with that presentation, I'm going to show you, I think we all agree probably needs more. So when you see this on your OCT, I'm going to show you this in a couple there, so you can see a couple things. Peter, anything that worries you when you look at this OCT? I wrote it all there, what you should be worried about, but you can tell me what you see.
Yeah, no, I've been looking at a lot of these. No comment.
So, VIT cell for sure, I think we can see, and this full thickness hyperreflectivity that I think you'll see here on the map.
Do you think on that OCT you got very early on there was any cell?
In the right eye, the original one, there wasn't any. I actually went through the cube and looked for it. I didn't see anything, but actually, I take it back. I didn't have the cube. All I had was the one line, and then the follow-up one, I looked for cell and I didn't see it.
Because it's interesting, you said occlusive vasculitis for the right eye, but we really didn't see vessel staining.
100%.
We didn't see other features. So
I worry about 25-year-olds with CRAOs. I don't
Oh,
believe it.
yeah. But I'm not sure I would have called that occlusive vasculitis.
No, I said it was in my, certainly in my differential. And I think that's some of the point here. Sometimes you catch these at different time points. So now here's the OCT beautifully on the map. You can see these multiple lesions. And here's the OCTA. Does anyone want to tell me what they see on the OCTA, just for everyone's? Vas, what do you see on this OCTA that is interesting to you? Anything?
Yeah, well, I mean, the OCTA, actually, honestly, the OCTA is not a really good quality. Sorry, Sunil. But
I didn't take the picture. I don't know what to tell you, man.
Yeah, so it's
sorry,
hard.
man. I wasn't there. I was on vacation for the one day, Vas.
I think you're trying to assess sort of the deeper capillary plexus because you saw all those PAM lesions, but I can't really make heads or tails out of actually what the perfusion looks like.
No, I agree. I think the PAM lesion, I think, is probably the idea that there's some decreased perfusion here, and I think I'm going to give you the perfusion map here in a second. I think I'm going to show you the fluorescein here a little bit. That just shows you this is post-steroids on the top line, and on the bottom line, on the bottom panels is pre-steroids when the patient presented. And just to show you, the patient actually maintains pretty good perfusion, but it's slowed in this scenario. So this is a scenario where this patient actually has vasculitis. It just shows you the presentation of vasculitis sometimes is quick, comes fast, does its damage, and walks away. It's kind of like, relatives who just stay at your house. They just cause a mess, and they don't do anything about it until they come back next time. This patient actually started on immune suppression, and I think actually has Behçet's disease. And so my question to you is there a scenario, and I was leading everyone here, but CRAOs have a very distinctive, we should send to the ER. Is there a time, Alexandra, you mentioned the older patient, I'm showing you a younger patient. Are there any other clinical signs we can tell fellows here or our colleagues where we should consider doing more for the CRAO patient? Anything else that you, like any other clues or tips? Adrian, you got it? No?
I'll plug the CRAO and the sickle cell patient, the young people that can show up with a CRAO acutely. The hematology treats them like a stroke workup, so they might get exchange transfusion to the ER as well.
Yeah, absolutely. And so some of this is happening in the ER, and some of this stuff that you can actually occur there. But sometimes it's really helpful to have that like kind of early image, even a fluorescein for some of these atypical presentations. So fluorescein's not dead. We still have to use it, even because Vas will tell you my OCTAs aren't very good. They don't meet VASADA standards. I'm sorry. That's just how it goes. All right, why don't we end on that? Thank, of course, iVista. Thank you to the whole team. I want to thank our sponsors again, if you want to pop them up, and all of our exhibitors for taking the time. Our panel, starting with Ricky, working all the way down to Peter. What a great job. Aaron, thank you. Adrian, Dan, always thank you. Alexandra, Vas, sorry about harassing you. And Justice, doing a great job as always. Have a great ASRS, and we'll see you guys around. Thank you.